Good morning to everyone. Today it's a very special day, friends, huh? Isn't it? Today it's International Vitamin D Day, and we are meeting with that same common energy to bind us. So, first of all, wishing you all a very happy International Vitamin D Day. And I feel it's not just once a year, every day should be the Vitamin D Day, because point is that it is needed for us all on a way that our levels are well maintained, like we discussed yesterday. So I'm so happy you all are here, but I think we need to wait a while. Sunday morning, it seems, huh? Let's wait for a while till people join in. Okay. Maybe in case there are some questions, Vidya, in the meanwhile, which are unanswered yesterday, would you like, in case there are some, maybe we can do that till people join in?
Okay, I have to see first the question because that was on the link yesterday and it doesn't appear now.
Okay, no worries, no worries. It's all right. It's okay. Because anyways, we are going to briefly touch upon everything. Yeah. So I think I'm going to start within 2 minutes, sharp 10, and I'll do a little recap of what we did yesterday. We'll do a little recap. Okay. Right, friends? Would request you all to please keep yourself muted when the talk is on. Yeah. And yesterday we were seeing a lot of pen marks, and I did try to remove the annotations. Ferdy, can you tell me how to do it right now so that it doesn't happen itself?
Dr. Reno, I think the scratch coming from your side. Maybe when you do the presentation,
Really.
maybe you
Really?
no?
Okay. Okay. I don't
Okay.
think so, because I
Okay.
had put it off there and then I used the eraser to remove what was already there. But anyways, I will see that it's not happening from my end. In case it was, sorry for that.
It was not from your end because it shows the names of the people who were annotated.
Oh, really? Wow, that's smart. Okay. Thank you for protecting me. It's okay. I'm just joking. Huh? Thanks. Yeah. Okay. So I think I'm going to start. Kindly, buddy, see that we are not getting extra sounds. Please mute yourself, huh, doctor? Yeah, cool. Thank you. So friends, very special good morning to you all today. And it's the International Vitamin D Day, and I'm feeling very nice to have you all today with me. And we are an expanding family of doctors who are aware of the very vital role that vitamin D plays in health, not only for people who are suffering, but for preventing so many problems. And our yesterday's session was, I'm sure, an eye opener for many of you, where we touched upon the first compartment. Remember, I told you when it comes to vitamin D, let us think of vitamin D from two angles, or let us say we compartmentalize our mind into two. One is general supplementation, all right? Because vitamin D is food, it is food for our cells. And when vitamin D is in order, our cellular mechanisms are in order. My dear friends, healing is cellular. Healing happens. Kindly mute yourself, please, whoever. So, healing is very cellular. Okay. So, once the cells are working in order, and vitamin D is something which is unmatched, it's like an umbrella vitamin. I call it an umbrella vitamin, right? When the umbrella is strong, everything else is very well covered and functions equally very well. Okay. So, one compartment was how to deal with deficiency. And the target is 50 to 60 nanogram per ml. Ferdi, please see everybody is muted. Mr. Ferdi, please see. Thank you. Yeah. So 50 to 60 nanogram per ml is a basic must for everyone. We can no longer accept 20s and 30s, even 40s. 50 to 60 is the minimal requirement for orderly functioning of immune system.
Pretty strong in it.
Yeah,
It's
okay.
really
I'm sorry there is a lot of disturbance and it breaks the flow of sharing. Yeah, thank you. So, where was I? Okay, it's important. Now we decided also to have another compartment in our brain because we are doctors and we have to deal with people with problems. Our focus has been autoimmune disorders, where we realized how vitamin D plays a role in its genesis. And when we have to deal with patients of autoimmune disorders, we have to go into the second compartment, where we are dealing with vitamin D resistance and not just deficiency. Resistance means vitamin D levels can be adequate, but the effect is not happening. The biological effect of vitamin D on the functional part is not showing up because there are genetic polymorphisms at the level of the vitamin D receptor. All right? And that's why it's happening. And the way to combat this VDR or vitamin D receptor resistance is giving more doses of vitamin D, which my guru, my teacher, Dr. Coimbra, has installed into my mind, into my soul, my dear friends, that it has really become a calling to me. Helping people out with their autoimmune disorders with vitamin D is so crucial, and we don't, doctors, even check the levels that we saw yesterday. So friends, we have two compartments in the mind, and I take this opportunity to pay all my reverences to my teacher, to my guru, Dr. Cicero Coimbra, who has given me this confidence and the encouragement to spread this light, this real sunshine in the lives of my patients and possibly through you all with so many other patients, because one doctor is one community which gets the benefit. Okay, so with this background, before I start the presentation, I take this opportunity to introduce you to Jen. Jen, are you there? Jen Aliano, she's from the US and she represents a very powerful organization, a powerful research humanitarian organization called Grassroot Health. You can very well go on their website. They have unbelievable information and they keep, getting the things in order, updating them. Lots on vitamin D there. Very, very important part there. Many of the slides which I've used here also, a couple of them are from Grassroot Health. So Jen, can I please ask you to come on screen for a minute? Jen, I saw you. Hi, Jen Aliano. I hope I'm reaching you. Okay, maybe she cannot unmute herself. Sorry for that. Fendi, can you see that Jen can unmute herself and come on the screen, please? Jen. Yeah, thank you. I hope, Jen, you can do it now.
Oh, can you hear me now?
Hey. Yes, but I can't see your pretty face.
Okay, let me try to do my video again. I don't know why it stopped. And
there you are. There you
Hi.
are. Hey,
Thank you.
Nice to see you.
It
Good
is
to
so
have
nice to see you. Thank you so much for having me and for giving me this opportunity. And I apologize. I hosted a 2-year-old birthday party today and I forgot my computer. I forgot my charger.
It's all right. No problem as long as you're here.
But thank you for having me. And it's such a pleasure. I'm incredibly grateful to say hello and to be introduced here. So I am the executive director of Grassroots Health. And we were started to basically represent, we're a nonprofit organization in the United States. And we were founded as representatives of the vitamin D researchers. We started with a signed consensus from 40 of the senior international vitamin D scientists to say that for general health, for the general population, a vitamin D serum level of 40 to 60 was what was defined as optimal or the target. And we've expanded beyond that. And we also are very well aware of the therapeutic uses of vitamin D, such as what Dr. Coimbra and yourself teach. But we are constantly fighting the misinformation out there, the guidelines that have taken a major step backwards in the last year with the Endocrine Society, trying to erase the confusion. And so we do a lot of education around that. And I'm happy to have Dr. Matani as one of our very first featured scientists or speakers for we're starting a vitamin D study hour webinar every Wednesday at 11 a.m. Pacific time, where we will have a vitamin D researcher on to share the findings of a recent paper or one of the most important papers. So Dr. Matani is going to be covering a very short review of her recent paper on psoriasis, followed by open question and answer. Thank you for sharing that link. Yes, grassrootshealth.net. And then the week following, Dr. Bruce Hollis will be talking about prenatal vitamin D levels and how they affect neurocognitive development among children. And the week after that, Dr. William Grant will be discussing the importance of vitamin D, of looking at the totality of evidence and how randomized controlled trials are not designed for vitamin D research, and guidelines, unfortunately, have been set based only on randomized controlled trials. And so the importance of including observational and other types of trials really needs to be reconsidered. And I could go on and on about all the things that have gone wrong with our guidelines and the institutions, but everybody is welcome to join. They are free. We have a lot of other amazing resources, and I love seeing the charts that you use from us. Some of them I made myself, and I just really appreciate anybody who shares any of our information, any of our resources. They're all free to use. We just, I think we agree the more people who are aware of this and understand the importance of it, the better.
Thank you. Thank you so much, Jen. It's really, really very encouraging to see you here on this most opportune day. And
oh yes, and happy
light.
Vitamin D Day. It's not Vitamin D Day yet for me.
Absolutely. And we look forward to working together for sure with the same mission in mind. And I take this same time to invite all the participants to join this webinar every Wednesday. So it is 11
a.m. Pacific time.
Yes. So for us, it is going to be a little tough in India and East because it's going to be around 12 midnight.
They will be recorded. We will be recording
so maybe we
them. We share all of our information for free.
Right. So. That'll be wonderful. That'll be great and wonderful. Thank you so much, Jen. And my dear friends, I have to share something in front of Jen. I have decided today to start a movement called D-Magic. Okay, D-Magic. And I have shared one flyer with you all where I've highlighted the points of the necessity of vitamin D for communities. So the function of this will be that anybody who shares their vitamin D report with me on the email dmagic@gmail.com, we will give them a free prescription of the vitamin D they need for general purpose because people are lost. They don't know how much vitamin D to take. We are not covering diseases here because that cannot be generalized. But for general purpose, for optimum balanced health, preventing problems, let us say compartment number 1, how to deal with vitamin D deficiency. We need the people's report by email. We don't converse because I'm sure this movement will take a big form. We cannot be talking to everyone and then problems come in. We will correct the vitamin D levels of people with free advice to them. That is what I'm starting. And I hope if needed, I get support from you all, maybe in your country. And one another tenet of this will be for my city people. Once a month, I will distribute free vitamin D. And I'm going to fix that date and put it up So all the people who may not be able to afford it, they can come to my place and they will be given vitamin D free of cost for that month, 2 month supply, and they can keep coming and renewing it. So please bless me in this venture. The purpose is the same, to spread the light, the sunshine in the lives of people. Thank you very much for being there to support. Should we
Thank you.
start? Thank you, Jen.
Yes.
I think I will now start my talk. Should I, Jen, or you have to say something else?
Oh no, nope, I'm good.
Oh,
Just
cool.
thank you again. And what you're doing is incredibly important. We also have a vitamin D calculator on our website. It helps to calculate a personalized dose. But
We
yes,
lost
knowing
you,
that
Jen, huh?
vitamin D number is the number one most important thing anybody needs to know about vitamin D.
Yes.
Because you do want to get it up. I heard you say 50 to 60. That's fantastic. Yes.
Thank
Even
you.
higher with
Thank you, Jen.
autoimmunity. All right.
Yeah.
Thank you for having me.
That will be accepted. Thank you so much. Thank you very much for being here. And I really appreciate your joining at this time. Okay, friends, so now let's get back in expanding our knowledge. So I had a few questions from you all coming to me separately, and I thought I would just revise that part which we did yesterday, how to cover up the deficiency, the doses, that is what you wanted to know. And doses means how to do it. And then we'll move on to the Coimbra protocol and autoimmune disorders, right? So give me a moment. There we are. Okay, so we have sunshine in a pill, in a capsule, in a tablet with us. Thanks to the pharmaceutical industry for making it for us. Otherwise, I don't know how would we have managed this pandemic of vitamin D deficiency with all the problems of today. So friends, I'm just going to recap 5 slides for you and then move on. One was this, and as you can see, this comes from the paper of Dr. Vimla Vansa. He is from New Jersey, US, an endocrinologist, a very pioneering vitamin D enthusiast. So this slide shows that commonly, which we see, if the vitamin D levels are 10 nanogram at the baseline, and the person starts taking the routine formulations available with 400 IUs daily, 1000 IUs daily, or even 2000 IUs daily, the levels really don't go up. They are still under 30. And we are targeting at least 50 to 60 nanogram per ml, right, for optimal defense system, defense functioning of the body. So, well, if it takes 3000 per day, it may touch 40. And if it is 5,000 a day, then it will take 7 to 8 months, sorry, more than that, a year or so to cross 50. So that's quite, and then there are so many other factors which would affect and the outcome. So this strategy of low dosing will not help us reach the target. And there are other factors, as you know, obesity, older age people needing more vitamin D, certain ethnic groups, dark-skinned people needing more vitamin D. So I shared with you 3 strategies of planning. You can choose any. And I'm quoting Dr. Zaidi here. He's another one, and he has lovely books on vitamin D. Compartment number 1 we are talking about. So as per his book and recommendation, which I find very wise to follow in clinical practice, if somebody comes to you with vitamin D less than 10, you can start 15,000 IUs per day. It's a real deficiency. It's like the car being on reserve, no gas, no petrol. So you have to put more. 10 to 20 nanograms per ml, approximately 12,500 IUs per day. 20 to 30 level, all right, 10,000 IUs per day. 30 to 40, 7,500. 40 to 50, you're reaching the target, all right. Then you can think of giving 5,000 IUs per day. Okay, and body weight is important. So if somebody is 65 kg or above, he recommends that for every 10 kg increase, you add 1,000 IUs per day. And vice versa, reduce it if the weight is less than 65. Kindly mute yourself, Dr. Trianti. Kindly mute yourself. Can you please see everybody is muted? Okay. So now this is there for sure, but it doesn't mean you have to follow this only. I say if the levels are less than 40, just give blindly at least 10,000 IUs per day. It is so simple. This is the least we can do, and these preparations are available. You don't have to titrate 12,500, 7,500. If you cannot, forget it. Under 40, yeah, but yes, if it is under 10, 20, you have to give a loading dose, which I'm coming to. And once it crosses 40, fine, you can maintain it with 5,000 IUs per day. All right. Dr. Coimbra's suggestion is something which is body weight based, which is very, very scientific, very, very valid. 200 IUs per kg body weight per day. He recommends it for children. And well, I have seen this works well even when we are starting vitamin D supplementation for even adults in general purpose. 200 IUs per kg body weight per day. Children also need it. I got a question. Do children also need vitamin D? Yes, my dear. They all need it. In fact, they need it more because they are grooming their immune system. They are developing it, right? That's why we give them all the vaccines and all at that age, right? Because we want the immune system to take up something, but it should happen optimally, neither less nor more. And that's where vitamin D is important in the bodies of children to develop a proper balanced response to any vaccine for that matter. Okay. And then in adults also you can start. And once you see that, oh, the levels of say 3 months, you've given this dose, which takes at least 3 months to reach acceptable level, then you may reduce the dose in adults to, remember yesterday we saw the slide, 150 IUs per kg body weight per day, right? Recap, done. And this was my, what should I say, another concise slide for you all. Because, like for example, in India, we do not get 10,000 IU preparations easily. We don't get them. We get 1,000, 2,000, or 60,000. Okay, there's a big window in between. So what do? But yes, we're lucky we get 60,000, right? We have so many preparations of 60,000. You guys wanted to see the preparations. All right, we have so many, huh? They come as powders, sachets, gel caps. Now this each gel cap has 60,000. All right. This each nano bottle, nano preparation has 60,000 IUs. Okay. So now when I'm deciding how much to give, please mute yourself, Yenny. Yeah. So where was I? So the target is 50 to 60 nanogram per ml. If somebody comes to you who has blood levels of 10 to 20, means the card is on the reserve, or let us put it another way, not taken any vitamin D for more than 6 months. All right? They fall in the same category. We give them a hammer dose, like we fill more petrol in a car on reserve, more vitamin D. So we use the 60,000 preparation available here. Friends in the West, you also have 50,000 per preparation. Yeah. As I told you yesterday, Middle East has 25,000, 50,000. And yesterday, only one of my patients from the French area, they also have 50,000 preparations, right? So we have these loading doses available. And of course, in your Eastern countries, also you get it now. So then we give the hammer dose of 60,000 daily for 5, I correct it, 5 to 10 days, depending upon the weight of the person, depending upon, the levels. If it's just 10, I would give it for 10 days. 60,000 daily for 10 days, which also equates to the injection we have in our country. 6 lakh international units used intramuscularly to meet the deficiency. That's like 10 capsules or 10 tablets or 10 bottles of this 60,000 international units vitamin D. Okay, so 5 to 10 days done. And then we start them on 60,000 weekly or 10,000 daily for 2 to 3. I'm generous. I say 3 months. Yeah, give it more, doesn't matter. So you're giving food, you're giving nutrition to the cells. And ideally, you should do a blood test after 3 months to see that, well, how much the levels have come up. Okay. And once they cross 50, 60, you come to the maintenance dose, which is halved. All right. And if it has not crossed, let us say it is still 30, 40, you see such reports. Yeah. then you need to continue the same dose weekly. 60,000 weekly or 10,000 daily, and check it after another 3 months, right? Now, if it reaches 50 plus, blood levels 50 nanogram per ml plus, then you reduce the dose by about 50%. So you give them vitamin D daily. How much? 5,000 IUs per day. Sorry, where is it? Here, 5K daily, or 60,000 once in 15 days. Once in, what do you call it? 15 days. Sorry, there's an error here. And this also has a category of, I'm sorry, I'm lost. There, once in 15 days. Yeah. And then there's another category of people who could come to you with levels of, say, 25 to 35, or who are taking some or the other form of vitamin D in the range of 1,000 to 5,000 IUs daily. There you need not give the loading dose. You just give them same 60,000 once a week or 10K daily for 3 months, and then the maintenance dose, which is halved. So I hope it is clear. This is general purpose recommendation, which is safe, which doesn't carry toxicity, okay? And honestly, which does not need K2 also. K2 is not a must for compartment number 1, especially in our countries where we don't get K2 easily, okay? We should not miss on giving vitamin D because Google says that K2 has to be given. We should not miss the umbrella. You can miss a shawl, a sheet, but you don't want to miss the umbrella. So don't miss on giving vitamin D if K2 is not available, right? We do have preparations now coming up in our countries where vitamin D and K2 are combined, right? So it could be having K2 50, 55, or 100 micrograms per preparation with 1,000 IUs of vitamin D to max, I have seen 5,000 IUs vitamin D along with the K2. Now, if somebody's taking it, we have no problem with that. We have no problem, but K2 is not a must. And when you go to compartment number 2, friends, I told you there K2 becomes much more relevant, and we'll talk about it there, okay? There are preparations which have vitamin D, K2, calcium, magnesium, calcitrol, everything. For general purpose, well, maybe you can use it, but please see how much vitamin D it has. Okay, don't just say, it contains vitamin D, done. You have to see how much it has. Most of them have 1,000 to 2,000 IUs only. Okay, so if the patient is taking that recommended, let us say by for postmenopausal reason, or recommended by the orthopedician because maybe of some fracture, fine, let it go on. Just add the weekly or once in 15 days 60K to their protocol. You will not do any harm to them. You will do good to them. Okay, but they alone with 1,000 to 2,000 IUs of vitamin D per day are not enough to get your levels reach or remain maintained at 50 to 60 nanogram per ml. So once the patient reaches 50 to 60, you've given the maintenance dose, and then when to check the vitamin D? Hey, there is no mandatory rule. You see, it's an expensive test. It's a test which has been made expensive, okay? So, well, you can do it after 6 months. And once you see that, oh, all is in order, then they do it as a part of the routine testing once in a year or so. So, 5,000 IU daily becomes like a maintenance dose. Once the levels 50 to 60 are reached, okay? Right, friends? So these were my 5 slides to tell you the 3 modalities of, what should I say, the way we can give vitamin D to the people. Now I'm going to change my presentation and move on to the compartment number 2, right? Give me a moment. Sorry, just a moment. I'm a little lost, bear with me. There. So I have changed the presentation and I hope you can see it. This is the slide which I shared yesterday. I got it in one newspaper I was reading, which says that what is science? And these are some very powerful words said by no other than Dr. William Mayo. The Mayo Clinic names come from there. He said science is what? Science moves forward, okay, It's not stagnant. There is always more to learn. The ills of today do not cloud the horizon of tomorrow, but act to spur to greater effort, which we all are pursuing right now, because there are many closed minds, like even Jen agreed. It's not just in the eastern part of the globe, but everywhere. It's pan, it's global. There are minds which have blocks. They don't want to consider vitamin D especially important. So it doesn't matter. We keep working. We keep doing our job because it's all backed by science and we move ahead. Well, this is a very cute, what should I say, a cartoon. God says that I made a blunder. I forgot to complete the human body as far as the immune system is concerned. And I count upon you, my dear human being, to make it happen. Interesting, huh? Okay, so let's move on. What I have learned from Dr. Coimbra, and which is popularly known as Coimbra Protocol, we are trying to treat the cause of autoimmune disease, right? We are not just trying to suppress symptoms. No, that is not the target. So patients who come in desperation, I'm suffering like anything with this autoimmune, I have to see you immediately. You have to tell them, my dear friend, calm down. Because what we will be doing for you takes time. It is finally trying to correct the causation, and you may have to carry on with whatever you're taking for a while till this mechanism takes over, till vitamin D defense takes over. And then we'll see what best can be done. So we are trying to deal with the cause of the autoimmune disease. And what is that? Abnormal vitamin D metabolism. How can it manifest? One, deficiency. Vitamin D deficiency, well, it is with everyone nowadays. But the more important part in autoimmune disorders is that even if you correct the deficiency, that may not be the treatment ultimately for the autoimmune condition, because there is something called as resistance, which you have to deal with in a different manner. So we have to deal with deficiency and we have to deal with the vitamin D resistance. That is our compartment number 2. Remember, I shared this slide with you yesterday that what Dr. Coimbra says, I'm reading from in between, that vitamin D mechanisms, there are so many. How many years nature must have taken to develop? Millions of years to develop. And even if the pharmaceutical industry spends so many years, 400 years working on this. Kindly mute Dr. Santa, Dr. Kinneri, Dr. Santa. Thank you. Fendi, please see that everybody is muted right now. When there's a Q&A session, then I'll request you to please unmute. Thank you. Yeah, so it's a mechanism that took so many years, and pharmaceutical industry may spend 400 years, 500 years, but they will not get close to making one single molecule that can do all the functions that vitamin D can do. Yeah, so many mechanisms, so many pathways. Kindly mute. Dr. Ramesh, kindly mute, please. Thank you. Fendi, I'm requesting you to mute all the participants, please. We'll unmute when the Q&A session is there. Kindly. Okay. This was a slide I shared with you yesterday, proudly to share what's happening inside the immune cells when we take vitamin D. Okay. So vitamin D, that when I say, it means cholecalciferol. Yeah, cholecalciferol. D3, let's call it D3, simple. Okay. Well, it comes into our system, into the blood, through whatever source we are getting it from. Then it goes through the first level of conversion in the liver, where there's an enzyme called 25-hydroxylase. Adds the hydroxy on the 25th position to make it 25-hydroxy D3. Okay, that is the liver level. Now this, otherwise we read during medical school, gets converted in the kidneys. And we thought, oh, that is the only way. But no, dear friends, it happens in almost every cell of the body, and we are particularly focusing on the immune cells, where we look forward to intracellular production of vitamin D. All right. So this 25 hydroxy, somebody is raising the hand. Dipali, is it urgent? Tell me. Can you type or something? Then Vidya can. What's there, Dipali? Why your hand is up? Okay. So I think it's by mistake because I don't get any feedback from you. Okay, I'm carrying on. So yeah, then inside the cell, there is this ultimate enzyme called 1-alpha hydroxylase, which is represented by the gene CYP27B1, all right? And this enzyme is crucial for conversion of 25-hydroxy into 1,25-dihydroxy D3, the ready form of vitamin D. Okay, the ready, calcitriol it's called. The ready form is there, okay? Now, if there is a problem, please don't use your pen. Rose Mini, kindly erase. Oh my God. Give me a moment. I have to use the eraser now. Okay. All right. So, yeah. This is one important step in the whole process because we want this to happen inside the cells. Remember, friends, I told you? Then there are no fears of hypercalcemia because it's not happening in the blood. Hypercalcemia is avoided with this intracellular production of vitamin D, and two, we get it in better concentration rather than coming into the blood and then getting absorbed into the immune cells. Okay, so we look forward to this happening, and this enzyme is important. And then if there is a problem in this gene, if there's a genetic polymorphism here, this conversion will be inadequate. And then this is called as vitamin D resistance, one of the reasons. And so we have to give more vitamin D to combat this so that finally, it moves from 25 to 125. Is that okay? Yeah. Now, once this ready vitamin D has happened, it goes to the nucleus where the receptors for vitamin D are, vitamin D receptor. Okay. And there the processes happen in protein transcription and all those pathways to make the right proteins like T regulatory cells. We want the Treg cytokines to go up because they create a balanced immune response in the body, right? And then suppression of the harmful ones like the Th17, which is one reason for autoimmune disorders. Plus vitamin D, I discussed yesterday how it works on both innate and adaptive immune response. Innate means level 1. When there's a pathogen attacking, what happens immediately? Vitamin D recruits mechanisms that natural antibiotics, antivirals get made, like defensins and cathelicidins. Okay, so all this happens through the functioning of this intelligent molecule. What happened? All right. So finally, we see that vitamin D is trying to help strike a balance in the body. It doesn't want excess of Th17, right? But it wants to see that T regulatory cells are not deficient. Friends, remember we discussed yesterday how the recognition of T regulatory cells has been awarded with the Nobel Prize this year in medicine. T regulatory cells are important for immune system, for immune health. And the good news, vitamin D increases Treg functions. It optimizes T regulatory cell functions. Fascinating. So now the Coimbra protocol, what does it say? That vitamin D has a potent immune regulatory role. Okay. Autoimmunity is found to be associated with resistance to the effects of vitamin D because of genetic polymorphisms. To compensate for this resistance and the effects, what do we need to do? We need higher levels of vitamin D. 1, 2, it has to be taken on a daily basis. Friends, the half-life of vitamin D in the blood is 15 days, but inside the cells, inside the immune cells, it is found to be 24 hours. And that's why we have to give it on a daily basis to maintain the milieu or the environment of the cells congenial for immune functions to get properly modulated to the advantage of the patient. Okay. Now, it's not a one size fit for all protocol, friends. Please, I keep saying that because I keep getting this question. Tell me the dose for psoriasis. Tell me the dose of vitamin D for rheumatoid arthritis. No fixed dose. Okay? Think about it. You're more hungry, you will take 2 slices of, let us say, bread or chapati in India. Okay? If you're less hungry, you will do it one, isn't it? So there is no dose of your food for hunger. Same thing here, it's food. And we have to see the requirement and here the effects. So individual requirement of vitamin D varies based on the degree of vitamin D resistance that particular person has. And how do we monitor it? We do testing of vitamin D, not only that, but the parathyroid hormone level, PTH hormone, because vitamin D and PTH have a very good biological association. We'll recap everything. So we check PTH for that reason to see, is vitamin D working? Am I able to combat the vitamin D resistance in this patient? So we are not looking at just the level of vitamin D, we are looking at the change in the level of vitamin D. How much is the degree of change? Okay. And the second important test which we do is calcium monitor. For calcium monitoring, it is the ionized or corrected calcium, because this is the available or the bioavailable form of calcium, right? So, words of my teacher, he says that they started using vitamin D in the treatment of autoimmune disorders in the patient's own interest. The goal was not to do research or to convince anyone. It was simply to meet this basic principle of medical practice, offer the best benefit you can to your patient. If the patient is deficient in a known, well-documented, potent immunoregulator, correct that deficiency. If he has a resistance to it, give him a higher dose that can make up for that deficiency. Thank you, sir, for these very powerful words. I shared this with you also, that there's a wonderful paper by none other than Dr. P.J. McCullough, which reviewed vitamin D levels from toxicity angle in patients who were taking 5,000 to 50,000 international units per day, followed up over a period of 7 years. And, my dear friends, no toxicity, clinical toxicity seen. There were patients where levels went above 200. It's all mentioned in the paper. And they had taken it for treating their cancer also. It doesn't mean that people start doing it randomly. Yeah. But the point is, no toxicity was really observed. And I shared with you here, I highlighted here that in early 1930s and 40s, high doses of D were given to deal with many chronic disorders. Doses ranging from 60,000 IUs a day to 3 lakh IUs daily were shown to control asthma. 1,50,000 to 6 lakh IUs a day, it's a day, to ameliorate the signs and symptoms of rheumatoid arthritis. Say my pointer is here, okay? And a lakh to 1.5 lakh, same IUs a day to even treat infections like tuberculosis. So they were used in the past, but then in between, policies were changed. Policies were changed by the policymakers and the whole scenario changed. So now coming to PTH, vitamin D and PTH association, they have a inverse relationship. Okay, so as the vitamin D levels go up, the levels of the parathyroid hormone comes down. As the vitamin D levels will improve or the vitamin D is going to work, the PTH is going to come down. You may wonder why. Today we will discuss that. Why should this happen? We'll come to that also today. But let's understand this association in our context first, that is autoimmune disease. See, I'm sharing with you a report of a patient. This is how the patients may present. Low vitamin D and high PTH. The range of PTH varies from lab to lab. Okay. Unit also varies from country to country. See what is given on the side and follow that. Okay. So 15 to 65 picogram per ml for this lab, and this patient has very high PTH. And obviously, when vitamin D was corrected, we were looking forward to see, is it coming down? Friends, today in the second half of my presentation, I'm going to share with you so many cases, sharing with you all these reports, how we dealt with them. And I think that will be the real learning after we've understood the fundamentals. Okay, so you will see lots of case reports and how they had been monitored. Another patient, starting level 4.7, PTH super high. Somebody asked me yesterday that can we see low vitamin D and low PTH? Yes, my dear friends, we can see that also. And I will answer this little later because in medicine, in our human body, there are so many possibilities. I will explain, but right now, let's understand the dynamics between vitamin D and PTH first, and then we will move on to that sector as well. Okay, so when vitamin D is low, PTH goes up. Well, the reason, okay, I'll tell you. See, vitamin D is needed for absorbing calcium in the intestines, right? And when vitamin D is low, enough calcium is not getting absorbed. Howsoever supplements we may be taking, right? Supplementation of calcium, I mean, it's not going to be absorbed in the right way. So the body says, no, 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 I have to maintain the blood calcium levels normal because calcium is needed for the heart muscles. It is needed for so many intracellular functionings of transport of ions across the membrane. So the blood levels have to be maintained. Let me pull the calcium out from somewhere else. And where is it stored? In the bones. So the body decides, let me pull out the calcium from the bones to maintain the blood levels. And who does this signaling? PTH. The parathyroid hormone levels are up, giving us a message that this parathyroid hormone has got awakened to pull out the calcium from the bones. How intelligent our body is, no, friends? Huh? See how they signal to each other through chemicals. They communicate in our interest and we don't even realize it. Our calcium levels are maintained. Low vitamin D, but PTH is doing it for us by pulling it out from the bones. Yes, the bones do get weak in the process. Fair enough. It does happen. Okay? You understand this point? So that's why the PTH goes up. Now, when the vitamin D levels will be up, calcium will get absorbed. PTH will say, I'm not needed that much. So the levels will automatically come down because the parathyroid glands present near thyroid will not make so much of PTH. These are the signaling mechanisms of the body. So coming back to our vitamin D and PTH relationship, it's like a seesaw, friends. So when vitamin D is low in level or it is not working effectively because of vitamin D resistance, the PTH will be up. You may see patients, I have reports of people who come to me with high vitamin D and high PTH also. High PTH. Why? Because it means that person has vitamin D resistance. I have patients reports who come to me with vitamin D reports of more than 100, but the PTH is still up. Not very high maybe, but even if it is in the upper normal range, say upper limit is 65, they show a PTH value of even 50, but the vitamin D is more than 100. Well, that shows that PTH is not suppressed. If the vitamin D has crossed 100, I should have seen PTH really low, very, very low, 15, near 15 or maybe lower, maybe lower. I don't see that. Means the patient has vitamin D resistance. Okay. Now, if there is a deficiency, you cover it up. You're going to give vitamin D. Okay. The levels go up and hopefully it works. In autoimmune disorders, it may not work that much. And what do we expect? We expect that when we check the PTH again, it has come down. Okay, this means the biological action of vitamin D is happening. And if it is happening at the intestines, it will also happen inside the immune cells. Okay, Now, you cannot measure vitamin D inside the immune cells. Cannot. Okay, so we have to depend upon this PTH dynamics to understand vitamin D resistance. Somebody asked yesterday, is there no single blood test to know vitamin D resistance? No, my dear friends. You have to see the effect to know the resistance, and that is a change in PTH. I hope this is getting clearer today now. So, PTH suppression by vitamin D is the index of vitamin D utilization. How much vitamin D is used by the body is more important than just how much are the levels and how much it is being supplemented. If PTH levels are not dropping, the body is, or they're dropping very less, not properly. Let me use the word not properly dropping. The body is not making proper use of vitamin D due to vitamin D resistance and shows resistance. So it means that, well, I have to give more vitamin D to this particular individual. My report, friends, sometime when I was taking higher doses, I know somebody has asked me that please share your journey. If time permits, I will share my journey through my skin problem and vitamin D in maybe 2-3 minutes, a little later though. So when I was taking vitamin D for my psoriasis, for my LPP, that is lichen planus pigmentosa, okay, there was a time when my level was actually even above 150. I've had reports up to 160, 170, but somehow the print I lost. So I thought, let me show you the print. Okay. So this is somewhere after that, when the level was around 140, I get a call from the lab that, doctor, you are toxic. You have toxicity of vitamin D. They were concerned, are you okay? Because, you know, the lab people, doctors, we do know each other because the patients go. So I said, no, don't worry. I'm absolutely fine. Please tell me my PTH report, because I will always check PTH along with that. Because I was taking that time 50,000 internationals of vitamin D daily. No, this is the time when I was taking 40,000. Okay. So my PTH was 27.8, within the range. The range for this lab is 15 to 16. I said, don't worry. It's fine. What does it show? It shows that I have vitamin D resistance. Okay. Although my levels are above 100, my PTH is not 0. It's not 1. It's not 2. It's not even near the lower limit. That is 15. So this is an example of vitamin D resistance. Yeah. When I started my vitamin D treatment, that time my PTH was 55. My vitamin D levels in 30s, and my PTH was 55. So I started taking more vitamin D and see how the PTH came down, but it has never in all these high dose D therapy days of mine, and now it has never gone down below 23. The lowest I've ever seen for me is 23. But of course, my all problems are gone. Okay. So right now I'm on a maintenance dose, which is lower than 40. I take 20,000 daily. There are days which suppose I miss. So you can say on an average, it happens once in a while. But yeah, I can miss other things, but not taking vitamin D once in a while. So I take around 20,000 IUs daily, 15 to 20,000, you can say. Okay. So friends, PTH inhibition, excuse me, PTH inhibition is the most valuable index to adjust the daily dose of vitamin D. Okay. And the message is, if not suppressed as compared to I should add this here, if not suppressed as compared to the previous report, it is safe to increase the dose of vitamin D. Message conveyed, I hope, very clearly. Okay. So now, I hope any questions you'll have, we'll see later, but let's move on. So the lab test commonly done, vitamin D3 in the start. We don't insist that the patient checks vitamin D every time, because we want PTH and ionized calcium more frequently. Yeah, more in the beginning, approximately every 2 months, a couple of times, maybe 2-3 times, and then we space it out to 3 months, 6 months, depending upon the response. Okay. So yeah, then if you ask them to check vitamin D every day, every time, it's expensive, as I told you, and it doesn't serve any purpose, because we are going to decide the dose based on drop in PTH and not on the levels of vitamin D. For their own interest, they do it. But, I've always trained my patient before taking them. I've shared this with you earlier. I don't take random walk-in patients and write vitamin D compartment number 2. Compartment number 1 is okay, but not 2. For compartment number 2, I have to train them. I give them so much information, even if they don't read, I don't care, but I've done my duty. I want to train them, inform them, give them published papers, give them an FAQ, and I'm going to share. I think I shared the FAQ yesterday on the groups. All that goes to the patient. They know. I say, go and talk about this to your doctors, to your family, doctors in your family. Tomorrow, they should not say that I have taken you to toxicity, because I know I'm not going to do it. I'm not going to harm you. I'm your well-wisher. I've given up many lucrative things to do this work. So it's a passion for me. So vitamin D levels, we don't check always, but if the patient does it, we inform them beforehand. And when it's for academic reason for me, my database increases, as I told you. Friends, I have a software where I keep the record of all my patients very well. Even if they come to me after 7 years, I know their report 7 years back because it's all in my database. And that's how I can come up with research also, publications, hopefully more, because data is there. Okay, so parathyroid hormone is important. As I told you, now there are certain issues with their testing. Parathyroid hormone is a very labile molecule. Labile means it gets destroyed very quickly. Yeah. Vitamin D will not get destroyed even if the sample is checked after, let us say, 1 or 2 days. Similarly, calcium will not get destroyed, but PTH is labile. So ideally, it should be checked ASAP. ASAP means as soon as possible, hopefully within the first 6 hours of collection. But we cannot guarantee all that. So I tell my patients, at least ensure you're checking it from a lab, which will give you the result of PTH on the same day. Otherwise, what many labs do, they say, we check PTH. They send the sample to some other lab. And in that process of transportation, many times it is not checked on the same day, obviously. It goes on the next day, second day, third day. And then the report that will come to you will show lesser values of PTH than what actually it was. Okay, so this becomes a challenge. This is a challenge, and I don't say that I've been able to overcome it completely, because we do get patients from remote areas of the country. And there are many countries where you don't get PTH checked easily. Yeah, it's very difficult. And the labs don't give the results on the same day, blah, blah, blah. So, we have to also depend upon the clinical acumen of ours, see the clinical progress of the patient and take it ahead. So, theoretically, we have to realize that PTH should be checked on the same day. Friends, there are certain labs which don't do it. Usually, these are labs in cities which are not the metros. And 2 is many of the upcoming, I'll use the word upcoming, online labs. I don't want to take any names, friends, okay? Upcoming online labs. You don't know their identity. You just go on the website, you do a booking. There's some new name giving you a cheaper price, maybe. And we don't know. Because I have seen PTH reports of patients from such labs, level 1 at the start. 1, vitamin D 3 or 4, and PTH is 1 or 2. Can you believe it? So then I tell them, please go to a lab in your city where you are going, maybe physically, or to a hospital, which does it, get it done. And when they come back, the report shows PTH 40s, 50s, and 60s. This is very common. It happens. So just know this fact in mind. Now, this word intact PTH is one which is not destroyed. Let's put it like that. Some labs have technology to measure that. Some don't have. Fine. Moving on to so now there was a question that why do we see sometimes low vitamin D and low PTH also? This could be one of the reasons that the checking is not done properly or it's not done at the right time. That could be one reason of seeing low vitamin D and low PTH. So I hope I've answered your question. There is one more reason, but I will tell it to you later. Let our mind get a little more cultured to this protocol and how it is used. And I'll tell it to you today itself. Don't worry. All right, friends. Moving on, the other test that we do is ionized calcium, and I told you it is the bioavailable form of calcium. It's not the calcium that is bound to albumin or other proteins. And this is the active functional, what should I say? The functional uh, type of vitamin D. And why are we monitoring it? To see that the patient is not heading or landing into hypercalcemia. We don't want the patient to have very high calcium levels because that can be theoretically toxic. Vitamin D levels are not toxic. You understood that, Funda. We don't want them to have hypercalcemia. So that monitoring is important, especially when you're in compartment number 2. Compartment number 2, because we give high doses. Of course, we check other parameters which are correctable, like B12, why creatinine, renal functions. We want to keep a check on the renal parameters. There's somehow too much of a fear that vitamin D damages the kidneys. No, vitamin D doesn't damage the kidneys, my dear friends. It is high calcium that damages the kidneys. Okay. In fact, there are studies which show how nephroprotective is vitamin D supplementation. Even nephrologists give vitamin D to patients who are going through renal diseases. Okay, renal disease. Yes, the dose of vitamin D there has to be probably monitored. I will not say probably, has to be monitored better, especially if it's end stage kidney disease, because of the clearance problems. Like if a patient has end stage kidney disease, don't we reduce the dose of insulin, right? Because it will not get cleared off and it can lead to hypoglycemia. Same here. The monitoring is needed because we don't want hypercalcemia. Okay, so don't have that fear in mind. Please remove that thought from your mind that vitamin D will damage the kidneys. But we do monitor in compartment number 2, not only for ensuring that all is in order, because I have seen a couple of patients in this entire tenure of the last 6-7 years since I'm doing this work. I've seen so many patients of high dose, giving them high dose D. I've had 3 patients only out of those you can call, say, about 2,000 patients of autoimmune disorders, 3 or maybe 4, where I saw a little rise in creatinine after, say, 1 year or 2 year of taking. And they were those who were having diabetes for many, many years, who were already probably having kidney disease because of diabetes or because of severe hypertension, right? And the moment we slightly, we didn't stop vitamin D, just slightly reduced the dose, and a couple of seasons, the creatinine came down. One category of people is lupus nephritis. Okay, because lupus is a very common autoimmune disorder. If the patient has lupus kidney involvement of a high degree, end stage, you have to be careful about, because we don't want hypercalcemia. You can't give them high dose vitamin D as therapy. In the sense, I tell them, I have limitation. I cannot give you high dose D because your kidney functions are on the compromised side, and we just cannot give you more vitamin D. You'll have to take compartment number 1. So Dr. Coimbra says in such patients, give 10 to 20,000 IUs of vitamin D daily and don't cross more. Don't go beyond that. Okay, if somebody has this upper degree of kidney disorder in lupus patients, which we see. Okay. Okay, moving on. Where was I? Creatinine. And yes, TSH, I told you, I have seen that many patients who come to us with autoimmune disorders, they've already had Hashimoto's in the past. And many of them don't even know. We see TSH levels high. Functional problems of the thyroid are already there. So I think this is a message for us doctors that if you are dealing with any patient of Hashimoto's early in the phase, or let us say hypothyroidism, when they've just come to you, please ensure that you're correcting their vitamin D and bringing it to 50 to 60, compartment number 1 at least, because with this step of yours, you can prevent some other autoimmune disease from coming in the future. Okay, well, we measure the thyroids and we see that almost 30 to 40% of them have already are Hashimoto's or are not aware of it. So ionized calcium is this available calcium that we measure, let's call it free calcium, it is the most active form of calcium. And in case the lab is not able to check it, in case your lab is not they don't do ionized calcium, some labs call it corrected calcium. You can also check 24 hours urinary calcium excretion, which is a very cheap test. In India, it hardly costs 300 rupees. 24 hours urinary calcium, but the patient has to collect the urine of 24 hours and give it to the lab. Okay, that is another way. And if you're doing that test, the cutoff is 250 milligram. If the calcium in urine is less than 250, it's fine. If it crosses more than 250, means there is hypercalciuria, or the patient is excreting more calcium and there are chances of more calcium in his, internal systems. All right, friends. Now, this is a very interesting slide. This is just to show you the dynamics between vitamin D, PTH, and calcium. Okay. Don't worry if you don't understand it, but I think I'll show it to you at this stage. So whatever source we are getting vitamin D, it gets activated. How does it influence PTH and calcium? Okay. So PTH molecule is the center of this slide. PTH levels are suppressed if vitamin D is high. You get this point, right? Vitamin D more, PTH will be suppressed. Red. Vitamin D less, PTH will increase. Okay, right? So if the vitamin D is good, PTH levels are suppressed. And suppressed means they're not allowed to go up, because what is the function of PTH? From the bones, it is going to pull out calcium and increase the level of blood calcium. Interesting. So vitamin D has function on this calcium metabolism through PTH. Of course, you can see how vitamin D also functions on the immune system, just to keep it in order. Okay. And once the calcium levels in the blood, how they influence, if the calcium is low in the blood, PTH will go up, because PTH will then pull out the calcium from the bone to keep the blood calcium levels in order. And if the calcium levels are high or they are more, it is going to suppress the PTH. Right? Clear? So you can see how this dynamic works between vitamin D, PTH, and calcium levels in the blood. Okay, this slide I'm going to skip now, but I'll come to it later. After we've seen some cases, we'll bring this point in discussion when we're talking about the cases. So, friend, this chart once again before you, extracted from that beautiful paper which I've shared with you on vitamin D resistance as the reason for autoimmune disorders. I hope you've read it. I told you to read it yesterday, and you must have seen this chart over there, in which clearly the dose over experience of giving high dose D under Coimbra protocol is being portrayed. MS patients need the highest dose of daily dose of vitamin D, in the tune of 1000 IUs per kg body weight per day. They may need it. You may start with, let us say, lower dose, say 500 IUs per kg body weight per day, but it is seen that you will have to increase it depending upon PTH suppression and all. Okay. Common conditions which we deal with: rheumatoid, lupus, psoriasis, Crohn's, ulcerative colitis, 300 to 500 IUs of vitamin D per kg body weight per day. Okay. Some conditions, lower dose 300 is fine usually, like Hashimoto's, ankylosing, scleroderma. By the way, scleroderma responds beautiful to vitamin D therapy. I told you yesterday, it's not mentioned here, thyrotoxicosis, Graves' disease. Oh my God, I'm so happy to share. I never thought. I can say that you can reverse Graves' disease with with vitamin D therapy. And they don't need high dose. They respond to all this, 300 IUs per kg body weight per day. Okay. I've taken off patients off neomercazole, and more than that, saved the thyroid, because they are normal. They don't land up into hypothyroidism. They don't go towards Hashimoto's because of the inflammation of Graves damaging the thyroid gland. We prevent the damage to the thyroid with daily vitamin D. Friends, daily. I hope I'm able to publish a paper on this soon. I want to do it. Yeah, this is something so beautiful, so novel, so unknown. Yeah. And this has happened to me with just doing it and seeing the results. So as I told you, MS patients need lots of vitamin D, and the dose isn't uniform. Dr. Coimbra has given doses of, actually, he gives more than lakh units also per day. And even I had to give to a couple of, not couple, quite a few patients now, but they were all MS patients. Huh? We had to reach that level to, let us say, crack the problem. And I told yesterday again, I repeat, the earlier we start vitamin D therapy, the more you get better results, reversals, and protection to organs from getting damaged. The earlier. So don't think that vitamin D therapy is if nothing else works. No, it's early so that you don't need to give any other thing later. You may not need it. Like I was told to take methotrexate. When I was going through my peak of problem, I had terrible psoriasis. This all was covered. Hands, feet, legs, joints, later neck, face, everywhere. So I was told you have a lot of it and you will have to take this methotrexate lifelong. Well, I was one of those who wanted to explore other things before get embarking on taking it. And that's how I landed up with all this that I'm sharing with you. So I didn't take a methotrexate tablet. Yeah, I didn't take it and I've not taken it till now. My first episode when I was told to take methotrexate was 2006 or 7. 6 or 7, yeah, that time. Yeah, so it's about 20 years now. We are clear with this fundamental. Okay, now there's a question which might come in your mind, how to decide the dose to start with vitamin D. I have this slide in front of you which I learned from Dr. Coimbra when I was there, and I do keep it in my mind. It's valuable. But honestly, friend, I have realized, and this also Dr. Coimbra taught me, that you don't depend only on this method. You have to see the clinical response of the patient. I told you that PTH level is not the target. That, oh, I have to reach 15 picogram per ml and then only my patient's autoimmune disease will come in control. No, no, not at all. If the clinical improvement has happened and the PTH is in 20s, 30s, you don't have to give more vitamin D. Just carry on that for some time, whatever dose has helped. Carry on for another couple of months. That's what I do. Once I see my patient says I'm 80-90% better, all right, and the PTH is safe, no hypercalcemia, carry on the dose for another 2 months. Let the mechanisms get corrected, because I've seen if you immediately reduce the dose, they come back with a rebound also. They can come back. Not rebound, little comes. It doesn't come like that massive attack type of a thing. So take it for another 2 months, 3 months. Let your mechanisms get corrected. And then I slowly try to reduce the dose of D. And I will share with you how with the case studies till I find the right maintenance dose for each patient. It's different. I have patients who are taking 60,000 per week now, totally out of their problem, and they do well with that weekly dose. Then why should I give him more? But there are patients who need more, like I need 20,000, 15 to 20,000. I've seen that. If I come down or if I don't take vitamin D, let us say for days and months, levels come down, I feel little irritability in my skin. Irritability, I will say. Okay, so I'm happy taking that dose. There are patients who are happy on 10,000 daily. There are patients who still need 30,000 daily to keep the problem away. Okay, because they needed a higher dose. Their vitamin D resistance was higher. So we have to adjust the dose based on clinical outcome along with PTH. PTH is just to guide me, can I give more vitamin D? That's it. Don't target PTH level to decide the success of treatment. Okay, just a guide. Can I give more vitamin D? That's all. Okay, so this is one, what should I say, methodology followed by theoretical. But Dr. Coimbra also says now it's all clinical, more of clinical, and PTH to guide me whether I can increase the dose or no. So now I'll just share it with you. This is just to show you an example. A patient comes with PTH of 60, okay, body weight around 60 kg, not obese, and the reference range for that lab is 12 to 65. Okay, so 60 kg, a patient of, let us say, MS, you decide to give theoretically 1000 IUs per kg body weight per day. This is just a theoretical example, okay? So we give 60,000 IUs per day. After 2 months, you check, PTH has come down by to 30, okay? And the improvement is 10-20% or maybe no improvement. And point is, you have to decide how much to increase the dose because the patient is not yet showing results. 30. So you follow the principle of algebra. You know, there's that calculation methodology that, okay, with this much, how much is the drop in PTH? 30. 30. So this 30, sorry, how much is the drop in PTH is 30. So with 60,000, the drop was 30. Now I want a drop of another 15. So how much drop I want? 15 between the two levels. So how much vitamin D should I give? It will be addition of 30,000, not 60,000. You understand that algebra principle? You can do those calculations which we have taught our children when they were in school. Okay, so now the dose becomes 90 theoretically. Okay, and this is how one calculates further. But friends, honestly, I don't follow this principle because number one, everybody is not MS patient that we give this high dose, and we have to see the mindset of the patient as well. We don't want to intimidate them as well. A patient, similar, there are other examples on the same funda. So we don't want to scare them out because if they are scared, when they start vitamin D therapy, oh my God, the fear is there. Huh? Don't think the fear is not there. Slowly that confidence comes in. So it doesn't matter. Start slow, but build confidence. So if the patient thinks that, oh my God, then nothing is going to work. There is enough publication that anxiety in the mind deranges immune functions. So it's a big boss. How we think, how we interpret, how we perceive, and how we react decides how we react to even how our emotions are. What is our resilience? All these things decide outcome, my dear friends. Huh? So don't think it's only these numbers. We have to develop congenial relationship with patients, the trust, the confidence. Then only they can trust vitamin D. Okay? So, yep, point is we don't intimidate them. And I have seen patients who come to me. I now tell them so many times, especially in compartment number 2, when I have to increase the dose, I again repeat and I show them, see, your PTH was this much, now it has come down this much. If you remember, it shows that, see that, and then I share them that seesaw picture of mine. I've kept a printout with me in front here. I show them that vitamin D, PTH, seesaw picture, see. Okay, since it has not come down, I need to give you more vitamin D theoretically. Are you ready? I asked them this question. Are you ready for it? Are you okay with that? I don't push it on them because I feel that even if they continue with what dose is going on, instead of increasing, as long as they are comfortable, it's going to help. It will help in the eventually better than the fear. Oh my God, I'm taking so much vitamin D. Morning they get up, my urine has come. Oh, my kidney is working well. You understand? This is human psychology. So I ask them and they say, yeah, you've told us so much, so many times, and we are ready to take it. Then I increase it. Moving on further, why don't we give the ready-made form of vitamin D? Sorry, I'm coming to this slide we saw yesterday, so I'm just skipping it quickly. How the vitamin D conversion is not just happening in the kidneys, but finally in the immune cells. Okay, yeah, I think there's some skipping, change of slide sequencing. So now there you are. Huh? Calcitrol, the ready-made form of vitamin D. 125, we get it, dihydroxy D3. Friends, it is expensive, okay? As compared to cholecalciferol, that is one very important factor because now compartment number 2 also and 1 also, they need vitamin D lifelong. Compartment number 1 needs much less, 2 needs much more, okay? It's food, I tell them, do you stop eating food? You will have to keep taking vitamin D, it is food for your cells, okay? So they know that it's not that I'll try it for 2 months and see and then stop it. Do you stop eating food is the answer of mine to them, and they know what they have to do. Okay, so So now this cholecalciferol is getting converted into the active form of vitamin D inside the cells. Remember? So there is less chance of hypercalcemia. But when you give the ready-made form of vitamin D orally, it will go through your blood into the immune cells. All right. And then it will create a lot of hypercalcemia in the blood. So we don't give the ready-made form. Number one is biggest reason is it is more hypercalcemic. Two, since it is going through so many barriers then inside the cell, rather than get it made inside the cell, it's like, indigenously made vitamin D rather than getting exported or coming from somewhere, imported from somewhere else. And third, of course, the cost. Daily, I told you we give vitamin D because, thanks, Jen, this is slide from your website, grassroothealth.org, .net.org, and vitamin D half-life inside the immune cells is 24 hours, while it is 15 days when it is, in the blood. So we have to give it on a day. The way we eat food every day, we need vitamin D more frequently than just taking it erratically, randomly. It should be available. This is a paper to talk about this, okay? Dr. Bruce Hollis, Jen mentioned, will be one of the speakers on Wednesday. I think the third one she said, okay? And friends, yeah, you're welcome to attend the coming Wednesday program where I'll be talking about my paper on psoriasis on the platform of Grassroot. I will share the link. Otherwise, I'll share the video with you all later. Same thing, different. Yeah, this paper talks about same giving daily, plus why many of the studies which we see on the net say vitamin D is not effective. Are the doses used are so less. Vitamin D resistance is not understood, not touched upon. So obviously we will not see results, okay? I told you a very important role which topical vitamin D3 can play in those people with any form of dermatological autoimmune condition. With topical D3, of course, there are preparations, a lot of tubes available in the market which have different derivatives of vitamin D in a tube form, which the dermatologists also write. Sure, many patients are already applying it, and they do come with the problems because the internal correction of vitamin D is much more important. But at the same time, it's found that local application of even cholecalciferol, there are mechanisms. It helps to suppress the extra proliferation of cells that is happening in the skin in any format, or the inflammation, or the mast cells which are infiltrating the cells and giving the itch. So local cholecalciferol has been found to be useful. This is, 25 hydroxy D they are talking about. Cholecalciferol getting converted in the liver, functioning, and even the direct form prohormone, that is the D working in it, okay? So we give local. And how do we do that? Give me a moment. They have found that in the skin cells also there is conversion of vitamin D into 25 hydroxy. Can you believe it? In the skin cells. Interesting. So how do we do that? Injection vitamin D. Okay, we get it in India. Hardly 80 rupees, 90 rupees, different companies, $1 cost per ampule, which has 6 lakh international units. Means 10 of these, each containing 60,000, 10 of these in that one ampule. This is used to correct severe deficiencies, intramuscularly used. But this just came in my mind one day. I said, how about applying it locally and seeing? And patients really feel nice and they respond better. The skin responds better. So now I tell them, one ampule contains, mix it in about 200, 250 ml of oil of your choice. Coconut oil, olive oil, almond oil. I somehow feel that when the skin is inflamed, mustard oil should not be used. Neem oil should not be used because when the skin is already inflamed, it irritates. It irritates the skin. So some of these oils which are non-irritating, you mix the ampule, keep it. You can use it for days. It's not going to get spoiled. And apply to the affected part of your skin after bath. And if you can, do one more time before you sleep. You make your skin moist, put little water and apply this. It gets better assimilated, or let us say absorbed deeper into the skin when the skin is moist. And in country, this is available usually. And if not 6 lakh, there are countries which have 3 lakh, 5 lakh IUs I've seen in European countries available. And if not, say for example, United States, there is a beautiful product. There are companies which make it in, there are drops, vitamin D drops. 2000 IU per drop. Can you believe it? 2000 international units, not per ml. 1 ml has 20 to 22 drops, friends. Let's not confuse that. Per drop, 2000 IUs. So I will tell you the name of those brands. I tell the patients, order that. At least use that drop, mix it in oil and apply to the skin. Okay. Now, of course, there you'll have to put much more because the concentration is different. This is 6 lakh. Can you believe it? And that will be 2000 per drop. So, around 50 drops, you mix it in 100 ml oil. So this is all arbitrary, my dear friends. Okay. And apply it. There is one doctor in the United States. I will call him more than a doctor. He is Mr. Henry, who is the founder, and he managed the website called Vitamin D Wiki, Wikipedia. Okay. Vitamin D Wiki. Just remind me, I'll type it on the group, WIKI. And my dear friends, oh my God, that website is full of publications on vitamin D. You talk about the topic, say you want to look about, let us say, rheumatoid arthritis. You will see everything out there. So he told me that his wife had some skin psoriasis. She applied directly vitamin D over there, these drops. And she recovered because it was just the early phase. I said, wow, it matches with what we are doing. Okay. Yes, of course, we do internal correction. So she was taking vitamin D also internally, plus local. So this is our local methodology of giving vitamin D. And hopefully then we don't land up giving very, very super high doses because the patient is getting the benefit of both. We've used it even on vitiligo patients, dermatitis, eczema, dryness, that atopic dermatitis type of skin. Psoriasis, of course, wherever there is dryness. All right, friends. So now a little bit about vitamin D toxicity before we take a small 5-minute break. What if I'm taking too much? You are not, because it's hypercalcemia. And there are enough studies to show that even 100, by the way, Endocrine Society of India recommendations was 150 is fine. Okay. There are studies, they say even up to 250 is fine. There is nothing like toxicity. Provided, of course, we monitor for hypercalcemia. Remember this paper I mentioned from Mayo Clinic? Anybody of you wants it, of course, I can share it on the group. I think I will do that. It's up to you whether you read it or not. This paper says there is enough evidence that it is vitamin D toxicity is the rarest medical condition. Okay. And it only happens when people take it without monitoring high doses, not the routine doses. Compartment number 1, don't even think of toxicity. Keep bringing the levels to 50 to 60, you're doing a favor to the patient. You're not making the patient toxic. Compartment number 2, yes, you have to cross 100, 150, maybe 200, 300. Once the confidence goes up, I say take your time, groom your minds. You don't be in a hurry to give very high doses. Start seeing the results even with lesser doses, and then your confidence will go up, because that's what even I went through. It was not easy for me to talk like this years back, but now I'm backed up with the confidence of results and the love I get from my patients, their affection, it's very touching. So there you are. Till the doses taken are more than 50,000 to 1 lakh daily for months or years without monitoring for hypercalcemia. Thank you, Jen. Once again, grassroots slide, which says that there is no toxicity below 30,000 IUs per day. They have concised the results of 15 studies, okay? And no toxicity below 200 nanogram of blood levels of vitamin D. So don't worry, 100, 150. We play with those levels, patients are fine in the beginning, okay? You don't have to worry at all. And if you're scared, your patient will be more scared. I'm sure you agree with me. So don't show your fears to them. Don't show your anxieties to them. And with time, start with compartment number 1, even with autoimmunity patients, friends. Okay? Even with patients with autoimmune disorders, start with compartment number 1, but higher compartment 1 means let the levels go up to 80, 90. You're fine. You can prove it. It's allowed. Okay. And then slowly, and you don't even have to worry about telling them that, we are going to take you into toxicity and all that. Do that first. Build confidence. And then once you embark on compartment number 2, then you can do all the PTH and all that stuff. Okay. Right. I'll answer your questions a little later, friends. Give me a moment. Okay. Should I do it now? I think so. Yes, there are questions coming up. So can I request our dear Fendi, Vidya, if you don't mind sharing some of the relevant questions which could be duplicating. And yes, I see my dear friend, Dr. Genti there. Hi, Genti. I'm going to definitely ask you. She's been there with me for years, like Dr. Vidya, and I have another great friend, Dr. Sara. I think, unfortunately, she could not make it for some reasons. I'm so grateful to you all for giving me this big family in Indonesia, big family of vitamin D fans from Indonesia. Dr. Paramjit, if she's there, she is the torchbearer in Malaysia who leads people towards vitamin D. Okay, so Vidya, questions, please. Genti will talk later if you don't mind, huh? Yeah.
Okay.
Thank you. Yeah.
Dr. Reno, somebody asked what email ID that to send the report of vitamin D that you.
I will tell you. It's D Magic.
Okay, later.
D
Okay.
Magic. Isn't
D,
it wonderful?
D magic, yeah? D magic.
Yeah.
Okay.
Vitamin D, D Magic. Okay.
Okay.
I will send it with you. Yeah.
Okay.
At gmail.com.
Okay. themagic@gmail.com. Okay. So, someone asking about vitamin D in sarcopenia.
Friends, compartment number 1 is my answer. Everything is in compartment number 1. Please give vitamin D anyway. Sarcopenia, no sarcopenia.
Whatever.
Give it. So there can be so many causes of sarcopenia. It could be simple diabetes, yeah. It could be polymyositis. It could be muscle dystrophy. It could be poor nutrition, lack of exercise. So many reasons.
Aging.
Give vitamin D compartment 1.
Yeah.
Yeah.
Will the absorption of vitamin D be hampered when we use it for leaky gut and IBS?
You have to use vitamin D to heal leaky gut. It's a good question. Definitely. So there the preparation matters. I will not use a powder there. I will give them the nano vitamin D, which has the best absorption. And at the same time, I will treat the gut. And I have a way of treating the gut, which I'll share with you in my next presentation. All patients need gut treatment. And it is by correcting, or let us say, treating the common infections of the gut. Till then, other things don't work. The best of things don't really work that much. So I will do that and definitely give D. Yeah.
Okay, Doc. The maintenance dose should be for lifelong or any
Yeah.
specific time?
Again, my answer is, do you stop eating
Sure.
food?
Yeah.
It's food. Okay.
As long as we want to be healthier.
As long as I'm living. Yes, you're right.
Yes.
Absolutely. As long as we are living healthy. Correct.
Okay. Have you come across any patient with increased ionized calcium with high dose of vitamin D?
Yeah. We do see that. And it's not just because of increase in vitamin D. It's also their diet. See, what we do when we deal with patients of compartment 2, we do a lot of counseling about diet. Yeah, I should have mentioned that. We see that they are not taking too much of calcium-rich food, right? So we ask them, what is your diet pattern? So if they are, like, for example, regular fish eaters, for example, we have to be careful. There are people who are regular green juice drinkers. Careful. Because juicing increases calcium rather than chewing the leaf. Juicing. So we tell them limit it. The best of things, you may be taking wheatgrass, you may be taking moringa powder, you may be taking spirulina powder. Please limit it for a while till we do your next check of ionized calcium and see if you are eligible to take it or not, or little reduce the quantity. At the same time, we don't want hypocalcemia also, friends. Don't think calcium is a horror. Calcium is a must. We don't want hypercalcemia. So we don't say stop calcium. We say limit it. We monitor that. And all these people who have come with hypercalcemia, later on we realize most of the time it is their diet. Many times they are taking supplements with calcium. They are taking some protein powder, which has calcium too much. So we have to keep a check on all these things. And of course, K27. These are the people who need K2. We, even though the ionized calcium initially was okay, we see that we are giving them K2, and look, magnesium anyways we are giving to everyone. But it can be managed. Even with, I've seen patients I have a patient who came to me with a calcium level of 1.49. Upper limit of ionized calcium is usually, again, lab dependent. Please see the lab and the unit. In India, we see the range of 1.6 to 1.33. So if it is more than 1.33, it's an alarm. Okay, so that gentleman had 1.49. He was actually fine. And this was honestly his first report before we had started him on high dose D. So these are the people you have to look carefully. And later on, if it comes, we monitor it. Check calcium levels fasting to standardize it. At this stage, I had forgotten to mention. Check it fasting, because if somebody has taken calcium rich food and then goes for a check, the levels are going to be different. So at least to standardize it, the PTH checking and this, what you call it, calcium checking, which we do more, I say fasting. PTH, it serves one more purpose. It's gone early in the morning, so they will check it on the same day. If you will check it in the evening, we don't know when it's going to be checked. And PTH level also fluctuates with the daytime. So standard morning checking. It can be managed, and seeing hypercalcemia on report is not mean that the patient is going through toxicity. Okay, we can correct it and monitor it and bring it in order. Okay.
Okay, Doc. Um, Intracellular vitamin D is the key for autoimmune disease management, and the PTH is the boss to monitor how much vitamin D to be administered. Serum PTH reflects serum calcium and serum vitamin D status rather than direct intracellular vitamin D levels. Please explain how if the serum PTH reflect the actual intracellular vitamin D.
Serum PTH is not reflecting intracellular vitamin D. Serum PTH is reflecting the effect of vitamin D. See, I get your question and I appreciate that. Vitamin D is working intracellularly for immune functions. Agreed. But vitamin D is also coming to you through your diet, isn't it? It has come as cholecalciferol and then it has gone intracellular. So this cholecalciferol, which has come to you through your food, through your supplement, liver conversion occurred, it will also get converted in the kidneys. Don't forget that. You can't tell vitamin D that you work only in my immune cells and don't do any other function. It will get converted in the kidneys. And this one, which was that endocrine function of vitamin D as a hormone, it circulates in the blood. It will go to the intestines. It will absorb the calcium and influence the PTH. So PTH is reflecting the action of vitamin D in the blood. In the blood. Okay. But not the intracellular vitamin D level. Okay. So I hope it is clear. Yeah.
Okay. Let's have a drink first.
No, don't worry. Carry on. That's water.
Even in children, we see vitamin D resistance. If yes, then we need to check PTH in children also.
If they have an autoimmune condition, yes. Why not? But not otherwise. Don't check PTH for general purpose, friends. Please don't waste their money. Let them spend that money in taking vitamin D. That's important.
Agree.
So don't worry. Only when you see that, oh, the patient has come to you for an autoimmune disease and you decided to go into compartment number 2 type of confidence you have, then do it. So for general purpose, we don't check PTH and ionized calcium. It's expensive also. Okay. And we just see the vitamin D level and give vitamin D. K2 also. People think that it's a must. It's not a must, friends. Vitamin D is a must in compartment number 1. If K2 is not available and you don't give vitamin D, it's wrong. So please give vitamin D. Okay. And K2 comes in picture only when you're using high doses of vitamin D. And let me tell you, friends, in India, I'm giving you Indian observations. We don't see hypercalcemia that much the way we see in the Western population. There are many genetic factors also. We don't see it. Probably that's why we don't have problems much with dairy as compared to other people in the world. Yeah? And please mute yourself. So don't worry about these things in compartment number one. Go ahead, please. Anything else? I have lots to share with you, friends. Huh? Then don't tell me I spoiled your Sunday. Okay.
Okay, will high vitamin D help with polycystic kidney disease?
Huh? Will vitamin D?
Help polycystic kidney disease.
Array, my dear friends. Vitamin D is important, number one, for everyone. You got the message. You just correct it and also do the other treatment for your polycystic stuff. It doesn't mean that you don't do the other things. Okay? Vitamin D is not a magic wand that, okay, I give vitamin D, then I don't need to give any other treatment. No, it depends upon the condition. But yes, vitamin D in high doses for autoimmunity, focus can be given, especially in the beginning. Okay? But for other diseases, please do, like, for example, a diabetic. Okay, you're giving vitamin D to keep the levels good. Don't say, I'm not going to give you your medications for diabetes that you're taking. You understand? Hypertensive, you have to give the medication. Okay, right?
Okay, what is the dose recommendation of high dose vitamin D for the patient on early stages of hemodialysis?
Again, my dear, it's all guided by reports. You will see it. It's all guided by blood reports. There is no dose for a disease. Yeah, but on hemodialysis, you have to really monitor more stringently. Ionized calcium, which is not done, by the way. Apart from vitamin D, parathyroid hormone levels, whatever be the reason of kidney disease, all these tests should be done. Now, we are not talking of autoimmune disease, okay? Any kidney disease, calcium monitoring is important. Ionized calcium, PTH, which is done by nephrologists, they do it, right? Vitamin D, and that is what is going to decide. But magnesium and all, yeah. So I can't say that this is the dose. We'll see. Don't worry. Cases are important. Genetic disorders, again, just keep the vitamin D levels in order, friend, because it's a genetic modulator. Fine. You do your best. You can't do, say, a genetic disease. There's a question. Do you give vitamin D? Of course. Compartment number one, do it. No. High. Keep it on the higher side. Right? Everything cannot be reversed. Please note, we all are human beings, yeah? Otherwise, we will become immortal. It's not like that. We do our best and hopefully the outcome gets better. Okay, next please.
Are we also
Dr.
increasing?
Dr. Meenal, yes, you can calculate ionized calcium. I'll appreciate if you can share the formula on the group for everyone. We'll appreciate that. Thank you. Yeah.
Are we also increasing the vitamin D resistance by giving high dose daily? I remember some source saying high dose is causing resistance. In such patient, there will be fast fall in levels after treatment.
No, we have not seen it, honestly. But yeah, we are reducing the dose eventually. And sometimes, like to some patients, I do this. It's just an inner, not because that gentleman or whoever has said it. There is a lot of anti-D propaganda, friends. Please note. There is lot of anti-D propaganda because it affects pharmaceutical industry. Okay. But the same pharma industry has made it for us. And it's great. So thank you for that. Right? So I do sometimes that I tell my patients that, all right, yeah, Meenal has given the formula for you guys. You can have a look. Total calcium in blood plus 0.8 into 4 minus albumin levels. You can see that will give you the ionized calcium. Thank you so much, Meenal. Okay, where was I? Where was I, Vidya?
In the Coimbra protocol for autoimmune disease, does vitamin D remain an integrated part of the treatment or
Yeah.
does it become a standalone therapy?
No standalone. But vitamin D is most important. You have to prioritize, right? It's the most important thing. Second is magnesium, if I have to prioritize. Second is it will not do without magnesium. Then other things are needed. Zinc, important. Because once zinc levels are in order, it helps to reduce the vitamin D resistance. Okay? Omega-3 fatty acids, very important in their own way. Good, or I'll use the word good fats. Vegetarians who cannot take fish oil capsule, take coconut oil, drink it, man. It's from your country. It's revered, it's prayed. Coconut is a item of prayer in our culture. Coconut oil, okay? Drink ghee if you can. If not, drink, eat it. Take coconut oil, drink olive oil, but take good fats. That's important. So yeah, it's an integrated thing. But if you give everything else and not vitamin D, the results are not the same. You get the point? It's like a teamwork. There is always a prime minister, there's a vice prime minister, there is a ministry. It's like that. You cannot work without the prime minister or the president. You understand? So vitamin D is that president or that prime minister. Yeah.
Okay, Dr. Reno. Actually, at what level of vitamin D is considered toxic?
No, that is the point, my dear friend.
So not
Vitamin,
toxic level.
as long as there is no hypercalcemia, you can give more vitamin D. I have patients, Dr. Coimbra has so many patients whose levels cross 400, 500, believe me. Yeah, they cross, but there's no hypercalcemia at all. And there is vitamin D resistance. So although the levels are up, the effect is not happening. And toxicity also would be an effect, no? Think about it like this. If vitamin D is toxic, if I say, okay, vitamin D is toxic, so toxicity will be an effect of vitamin D. Now, if there is vitamin D resistance, there will be resistance to toxicity also, no? Please understand that point. Okay. But point is, it is hypercalcemia, which you can keep under monitoring. All right. Should we take a small break? I see a hand raised, Dr. Rao.
Okay. Dr. Narasimha Rao, raise hand. You can talk.
You'll have to
Yeah, you
please.
can talk directly
Okay,
with.
let's keep it short and sweet because I want to share lots
Okay,
with you.
okay. Okay.
Yes, you can apply in psoriasis over the lesions, Dr. Satish. And whatever I can see, I'm answering immediately. Dr. Rao, can you please type or say, joint dislocation, vitamin D, ma'am? Yes, you can always give vitamin D. Give D to everyone, compartment number. Everybody falls in compartment. Entire humanity falls in compartment number 1. Okay? Right?
Can we have a scenario where PTH is 15 and there is no improvement, and how do we manage then?
Yeah, there is a scenario where PTH is 15 and there is no improvement. There is possibility. There are so many other factors. If the PTH has been checked correctly and that there's no improvement, there could be some infection in the body. The patient could be in too much of stress. Mind matters. Okay? And I always say there's something written here. Always, you cannot negotiate with everything. Okay? So it can happen. And 2, if the PTH is suppose not been measured correctly, that could be one reason. And 3, I think I'll have to say it now, that one reason why PTH could be low in autoimmune disease patients with low vitamin D is autoimmune hypoparathyroidism. I repeat, the autoimmune process has affected the parathyroid gland also. Got your answers now. Okay. So if that is happening, the PTH will be low. But we give them vitamin D. We still give them vitamin D. And you won't believe there are patients where the PTH improves with vitamin D. Such patients, because you are trying to treat their autoimmune cause of hypoparathyroidism. So we still give. So this is another reason. And I have seen with my experience that patients who have Hashimoto's history or hypothyroidism can have autoimmune hypoparathyroidism also, because finally it is the same area. Now, if there's an inflammation in your thyroid, there are 4 parathyroid glands embedded there. They can also get trapped in the inflammation. They're neighbors. They're the same house, not even neighbors, same house. Okay, so this is one big reason of low PTH also. Ratio, roughly friendly oil is just 1 ampule in about 250 ml of oil. Okay. Chalo, can we move on? So I'll just I need a 2-minute break and I'll join you with my next presentation. All right. See you guys. Hi, everyone. So should we move on? Yeah. So now I'm going to just briefly talk about, because there's no end to it, talk about some of the other stuff we use along with vitamin D, like magnesium and all. Quickly, I'm going to do that. And then we'll move on to the case studies. I have got, please mute yourself. Titi Noor, kindly mute yourself. Okay. So quickly, running through the cofactors, let's call them cofactors, and a bit about gut cleansing. That is very, very important to give better results. Let me say that. All right, moving on. So how to make this vitamin D therapy more effective, hopefully with lesser doses as we add all these things. Okay, and I told you the first one is magnesium. Magnesium, selenium, zinc, minerals, vital minerals. Riboflavin B2 I've mentioned here because Dr. Coimbra has found, especially in patients of multiple sclerosis, about 15% of them, around 15% of
8 में
them
ಆಗಲ್ಲ
have some
6 years
resistance.
baby
Kindly mute. So yeah, they have a resistance to even riboflavin, and that is needed in high dose as a cofactor in the ATP generation process inside molecules, all that NAD, NADP, and all. So he uses high doses of riboflavin when a patient is not responding. 100 to 200 milligrams of riboflavin per day. Normal preparations that you get contain 10 milligram, 20 milligram of riboflavin. Okay, so this is his experience on some resistant cases of multiple sclerosis. B12, I'm not going to touch here. We all know about it. Omega-3 fatty acids is important. Let us say good fat is important. Today, many of the chronic diseases are on a rise because we have got trapped in that fat-free fad. We are trapped in the fat-free fad. I see many youngsters coming, this diet, that diet, this diet is a crazy topic. Huh? I'm doing this, I'm doing that. You realize they're hardly taking any good fat in their diet. How can they ever be, and they land up with chronic diseases? All these problems because we need good fat to make the cell wall. Every cell wall, just imagine, if it disintegrates, we are more prone to infection, inflammation, degeneration. Two, we need fats to make our brain and the nervous system. Early, dementia, forgetfulness, memory functions, brain functions. Just imagine, brain is important to control everything. So good fats are important. K2, yes, of course, by now we realize the importance in calcium harmony. And briefly touching upon everything, friends, magnesium. This needs a lot of attention in our medical scene. I'm loudly saying it, especially in India, because we are absolutely not using magnesium to the way it should be. We can avoid so many medications for patients just with D and magnesium. Magnesium is called as a, miracle mineral. And there are reasons for that. This slide shows, number one, how magnesium is a cofactor in every step of vitamin D metabolism, almost every step. So if there is a magnesium deficiency, there is a vitamin D functional deficiency too. And magnesium deficiency is very common because the entire soil is depleted now. With all the extensive farming, the chemicals used, the soil is found to not have magnesium. So although it is present in green leafy vegetables, nuts and seeds, when checked, the magnesium content is hardly there. Okay, so the time actually comes when you see need of magnesium supplementation with the presentation of the patient. So what could be the common, red alerts that, oh, I need to take or I need to give magnesium to my patient? We come to that. So magnesium is important in activation of vitamin D. 1 second. Large doses, of course, we have. Compartment number 2, magnesium is a must. All patients, because you need magnesium to activate and you're giving high doses of D. So magnesium is needed in almost 300 reactions in the body. Now through NMDA pathways, I'm not going to get into details in the nervous system. It works on the entire brain, gut axis also. Okay, so if somebody has problems like, let us say migraine, amazing treatment is magnesium and D. Trust me. Yeah. And it also works on the blood vessels. It's a nice vasodilator. Early hypertension, magnesium. Don't we use magnesium to control very high blood pressure? We've learned it in emergency medicine. Status asthmaticus, we use magnesium. It's a bronchodilator. So amazing functions. Energy, oh my God, how the energy levels go up with magnesium supplementation. Then sleep, amazing. You take magnesium, you get a much better quality, much restful sleep. Constipation, magnesium is needed to, for better peristaltic functions of the gut. Magnesium improves gut functioning, okay? So it is involved in so many things. Fully supports pain relief. Yes, muscle, how did I forget? Muscle cramps. We only think of calcium deficiency for muscle cramps. No, my dear, it's magnesium first. Don't we see people doing Epsom salt leg soaks? What are they for? Magnesium. The beauty of magnesium is not just oral, it gets absorbed through the skin, the transdermal route. No wonder sea bathing is found good because sea has a lot of magnesium. Okay, the spas, they use Epsom salt bath and charge in dollars or big amounts. Huh? Hey, you can do it yourself. Just get Epsom salt, put it in a tub, in your bucket of water, soak your legs and hands, and you get relief from cramps and pain also. Okay. So, symptoms of magnesium deficiency: anxiety, weak bones, low energy, weakness, inability to sleep, premenstrual syndrome, irritability, nervousness, headaches. I told you migraine, abnormal heart rhythms, yes, of course, muscle tension, cramps, and fatigue. So, general purpose, it's important. Now, one thing that is important to notice, people come with magnesium levels report, which are normal. They say my blood levels are normal, but they have symptoms when you look at it. Now, magnesium is a intracellular mineral. 99% of magnesium is present inside the cell. And that is reverse. Calcium is more in the blood. Magnesium is more inside the cell. You cannot measure intracellular levels. And our body, it's super smart. It will maintain blood levels of magnesium at the cost of intracellular levels. So checking blood value of magnesium doesn't serve any purpose. Got it? So you can see a healthy cell has more magnesium inside. So magnesium is considered as the anti-stress mineral. It's a natural tranquilizer that functions to relax skeletal muscles, smooth muscles, and the mind. It's good for the heart, good for the muscles, good for the nervous system, NMDA pathways, and good to give energy and improve metabolism. It is, it's interesting to note that for every 1 molecule of glucose burnt, 54 molecules of magnesium get used. So even for glucose metabolism, we need magnesium. There it is. Every molecule of sugar you consume, it takes 54 molecules of magnesium for your body to process it. So a high sugar diet leads to magnesium deficiency. What are the causes of magnesium deficiency? Not just depletion of the soil. Our diet, stress. The more stressed out we are, we consume more magnesium. Okay? So it is such a common thing to see. I'm skipping these biochemical slides. Just it's an energy generator. No, it's needed to generate ATP, which is the currency of energy. Vitamin D pathways, it is a cofactor. It is the NMDA receptor antagonist and thus plays a beautiful role in creating a perfect balance in our nervous system. So magnesium is needed. Emotional stress reduces magnesium, reduces vitamin D activity, autoimmunity. So it's all a vicious cycle. Magnesium is a very, very important. Why are we deficient in magnesium? I told you, stress also depletes magnesium significantly. Sugar, high sugar diet, low levels in the soil. Please mute, Dr. Abbas, mute. Mute yourself. Oh my God, again we see pencil marks. Eraser, eraser, where are you? There, eraser, eraser, where are you? I am happy I learned how to erase it out. Thank you. Okay, then, this is interesting. Magnesium is depleted by certain drugs. And can you believe it? We use H2 receptor blockers so commonly. Acidity, people just take it randomly. Not only in East, even in the West, I have seen. Oh my God, how much people take H2 receptor, and we doctors also prescribe. Okay, they deplete magnesium. So on one side, they are taking H2 receptor blocker, depleted magnesium, and the vicious cycle of acidity never goes. Then excess calcium supplements can also deplete magnesium. Medicines like steroids are found to deplete magnesium. Okay. Too much of tea and coffee, too much. I don't say don't take tea and coffee, too much. And then, of course, fluoride in our toothpaste and all. Why it's not moving? Yeah. So we can't check for deficiency because the blood levels have the limitation, as I told you. We need to use our clinical acumen, and we don't give any harm to the patient. I use magnesium so much, I can't tell you. In India, for the doc, there are many international brands, and I think I will show some of them after the talk to you when I'm on full screen. I'll show it to you later. Okay, give me a minute. So total body content of magnesium, as I told you, inside the cells, it is so less. Sorry, in the blood, it is so less. It is present inside the cells. All these foods are supposed to have magnesium, but for various reasons, we don't get it intracellularly, which we discussed. And we have a functional magnesium deficiency, most of us. Best way to get magnesium, of course, I wish the soil was more depleted. I have a couple of my friends who give Epsom salt to their plants. And they say that you put Epsom salt water, the output of the plant is much better. So point is, we need it in the soil. And of course, supplements. The time has come now that we have to depend more on the vital supplements. Problem is there are too many supplements. So we have to realize that let's take the important ones first. Like for example, vitamin D. Okay. Many people have that thought that there are so many other things. Are we missing on that by just taking D, magnesium, selenium, zinc? Friends, these things that we are talking today, they correct cellular mechanisms. Let me give you an example. Say detoxification. Okay, detoxification. The most powerful organ for detoxification in the body is liver, isn't it? Okay. Now, does it mean vitamin D will not be a detox one? It is. It corrects all the detoxification pathways in the liver and makes it a better detoxifier. Isn't that interesting? Many people like to take products for detoxifying. I'm not saying don't take it, but realize that vitamin D is helping very significantly. And you take all those products and don't correct the vitamin D, it's absolutely incomplete. Even those products are not going to work the way we are expecting them to work. In fact, vitamin D improves liver functions beautifully. I have a patient, young girl, who came to me. I'll show you her slide also, for a skin issue. She had autoimmune hemolymph and her enzymes very high, in 4 figures. I didn't care for them, honestly. Care means I didn't expect them to change. I was giving her vitamin D for her skin issues on the face, and she had atopic dermatitis on the body. Friends, not only did her skin improve, I was shocked to see her liver enzymes normalizing. I'll show you the reports from 4 figure to 2 figure. Oh my God, the parents are so happy. I can't just tell you. Okay, so it works on the liver. Coming back to our dear magnesium, we need to take it in the form of supplement. Nowadays you get products called magnesium oil. Okay, online milta hai. Any muscle cramp, spasm, you can spray it to your muscles, and you can do it locally. Just put Epsom salt in water, soak your arms and legs, apply it to that area with soak it in a towel, apply it to the crampy muscle, painful muscle. It helps. And of course, don't forget to correct the vitamin D. The Prime Minister is important. Okay. Now coming to which magnesium. There are so many preparations. Magnesium oxide, which is commonly used in combination preparations. Honestly, friends, it is the most, what should I say, less good one. Not good one, it is not good. Okay, because it hardly gets absorbed. Yeah, it could be useful for some for bones, but not really for our brain, for the immune system. No, it doesn't reach there. So oxide, hydroxide, no, for that reason. Sulfate, which is Epsom salt, it's very good for local. Local means putting it in water, soaking. But if you take it by mouth, it is it produces diarrhea. It's a very good laxative. Too good a laxative. In fact, in, what should I say, in our ancient boarding schools, Asian cultures, many cultures, they take Epsom salt by mouth once in a month to clear the gut. 2, 3, 4 stools, gut clears off, done. Yeah, this has been there in many communities. So it's a very powerful laxative, and you cannot take it on a daily basis orally. Okay, it's bitter. It's not tasty, by the way. Carbonate, better than sulfate, but the best. There's one more which is not mentioned here. Hold on. Taurate is not mentioned, and then there is one citrate, magnesium citrate. Okay, so well, whatever is available commonly, glycinated. Glycine is an amino acid. So the magnesium is chelated with the amino acid. So getting magnesium glycinate, bisglycinate, or diglycinate, or they use the word chelated magnesium, is the best. Okay. And then citrate is also nice. I think I'll show you full screen. Wait, I'll wait for full screen. So in India, we get magnesium glycinate, my dear friends, all my Indian friends. It comes by the name of MGD3. And now I'm glad it has picked up. It has become popular. I think I had a. Okay, there it is. MGD3. Okay, you get this preparation. It has 250 milligrams of magnesium glycinate, and every country has their own preparations. Like I'll tell you some of them later. Show you them in picture format. Sorry, I did it in between. Since I spoke about Indian brand, there is one another good brand called Cramp-Off. Kramp, Cramp-Off by Jackson Pal. Why I have to tell the names? Because there are very few brands. Magnesium is very underrated. We hardly get magnesium, we get only calcium or magnesium in combination, and that too in an oxide form. That magnesium is of no use. Okay, so this glycinate, this solo magnesium preparations are there. This MGD3 comes with 1000 IUs of vitamin D. Name MGD3. Okay, so many times there are patients who say, I'm taking D3 also because my magnesium has it, but it is only 1000 IU. So you have to give them what you call it weekly or once in 15 days, 60K in addition to this, right? Yeah. So which magnesium is best? There are other brands which are showing in this slide. Other salts, like as I told you, magnesium glycinate we just discussed. Good for those with migraine or who have a deficiency. Not much of a laxative property, but it improves bowel movements optimally. And it's very good to induce sleep, anxiety, anti-anxiety, and reduces inflammation. Topical magnesium is sulfate and even magnesium chloride flakes you get, but only magnesium chloride is very high. It absorbs water, so it melts in humid climates. So chloride appears to have more healing properties, but it melts. But those sprays that we use, the salts of that contains chloride. Okay. Magnesium citrate, I said, this is studied a lot and it has a good bioavailability. I use it in patients also. We don't get it commercially by pharma companies, magnesium citrate, but there are some nutraceutical companies which manufacture, and nowadays you get them online, and I'll just share with you some of them. This is also a good one, and it has laxative properties, moderate, not as much as sulfate, it's good. Then oxide, as I told you, is not a good one, not very bioavailable. Sorry, you can see it is written here. Please don't make markings. Please, I don't want to use the eraser again. Oh my God. Ah. In a second, I'm doing the job of erasing now. One of them is refusing to go. Oh, thank you, went off. All right. Magnesium threonate. Yeah, this has a more neuro action, more on the nervous system. But it is, what should I say? Some people are very sensitive to it. We don't get it in India. It's available more for neuro use, but just for your knowledge and information. Malate, as I told you, good for muscles, fibromyalgic type of symptoms. Taurate, as I told you, good for the heart. Taurine is good for the heart. But it doesn't mean that you have to get taurate only for heart. You can use magnesium glycinate, all purpose, always available. Okay, right? This is that Epsom salt and the sprays that you get. You can use it for local application. If you're interested, there's a lovely book called The Magnesium Miracle. There are so many papers published on magnesium. Oh my, there's so much in literature too. But know that magnesium is very important. And I feel everybody needs it. We have some or the other symptom of magnesium deficiency. Okay. Symptoms of magnesium deficiency in every system: cramps, pains, aches, poor sleep, anxiety, tightness in muscles, headaches, constipation. We all fit. Okay, so riboflavin, as I just mentioned, I'm skipping this. I just explained to you, 15% of patients, it's needed in this NADP, NADPH energy conversion pathways. and they have a genetic, what should I say, resistance, 15% of MS patients. So high doses Dr. Coimbra uses for them, and it's needed for vitamin D activation. Okay, I'm just skipping about vitamin B2 history. It's all about history. That was all in Italy, in the island of Sardinia, where they found it out. 15% population, riboflavin. Now coming to K2. Okay, K2 is needed for strong bones, of course, and healthy heart because it optimizes calcium. There are different types of vitamin K, K1, K2, K3, K4, so many are there. K2 is the one for calcium. Okay, K1, K3, these are all for, like blood thinners. So usually K2 doesn't lead to bleeding disorders. But if somebody has history of bleeding disorders, then we don't give K2. You understand? There is no thing shown that K2 will lead to bleeding. But if somebody has bleeding disorders, you don't know about the mechanisms and pathways, we avoid giving K2 to those people. Bleeding disorders means hemorrhages and all. Okay. So now vitamin K, here okay. I want to just talk about two here because it's general for K. As far as K2 is concerned, these are the two factors. One is called osteocalcin and one is called as matrix GLA protein. One works on the bones, one works for the heart. And this is what K2, our dear K2, K27, it's called specifically, some subunit of it, which works upon. It works through osteocalcin and matrix GLA protein. How? Wait, I'll tell you here. So this now K2, matrix GLA protein, osteocalcin. Now what it does, osteocalcin promotes mineralization of bones, means it allows the calcium from blood to go into the bones. Okay, while the other one, the matrix GLA protein, it reduces vascular calcification, means it prevents calcium from entering the blood vessel wall. Interesting. And that's why K27 has gained momentum, to see that the calcium goes into the bones and not into the blood vessels, be it the heart, be it the kidneys. In fact, there are preparations of K2 for the heart, Like I remember I saw also in the US, there are many, 1,000, 2,000, or even 5,000 IUs of vitamin D with K2, one pill. Take one daily. Fine for compartment number one. If you get it, please take it. In India, we don't have such preparations by pharmaceutical companies. Some nutraceutical companies, Nutraceuticals, are doing it. 1,000 IUs of vitamin D with K. You can take it, sure. No harm at all. It's good for the heart anyways. Okay. But more vitamin D may be needed if it is only 1,000 IU in that preparation. So in India or otherwise, you can supplement that 60,000 IUs weekly, once in 15 days as advised. Okay. But if K2 is not available, please don't deprive yourself from the glucose. And that is what? Vitamin D. Otherwise, there will be hypoglycemia. Hypoglycemia can be life-threatening, isn't it? So we need the D first. Moving on. So this is what it does. Our dear K2, it sees that calcium goes into the bones and not, it goes into the bones and not into the blood vessels. The dose of K2, friends, this is just to show how it prevents calcification in the heart. So it's important for heart health. And in fact, in India, there was a company which was making K2 alone. And I used it in the beginning years. I used to use that, but they stopped making it. They stopped making K2 alone because they thought they will promote it through the cardiologists. The cardiologist should write it for all the patients of heart disease who undergo angioplasties and all. But somehow the cardiologist community did not promote it. Yeah, for reasons which we all understand. Nothing, we don't value supplements. That's a basic mindset, a basic training which we all, at least I have also gone through as a physician, MBBS, MD. Supplements are given like, okay, it's a chapter, but not the importance of it, the way it should be taken. So they had to withdraw the making of that product. Now there is one company that has come in India, which is making pure K2, and I will show it to you just in a minute or so. K2 is important for as an anti-inflammatory also. Sorry. Now it's found to have other roles, antioxidant, anti-inflammatory. So it is a good one to take. I'm not saying don't take it, but don't deprive of vitamin D because you don't get K2. One. And two, compartment number two, you will need to give more vitamin D in proportion to K2. You'll have to give more. You cannot say that I'll give K. There are some books which write for every 10,000 IUs of vitamin D, give 100 micrograms of K2. No, it's not like that. Suppose a patient is needing, let us say, 1 lakh units, 1 lakh unit, like Dr. Coimbra also says for MS patients, he's giving, right? You don't give 1,000 international units of micrograms of K2. In fact, Dr. Coimbra is a little not very pro that you have to give K2 in that proportion, which I agree with. I totally agree. So, compartment number two, max 300 to 400
अरे उसको बोला
micrograms.
उसका नंबर ही देख रहा है, मेरे पास नंबर बाजू वाले शिवाजी का है.
अरे हमको मत बताइए नंबर, म्यूट करिए अपने आप को. Kindly mute yourself. Why don't we understand this
10
thing?
लगाना.
Okay. So I hope I've conveyed the message of K2. So in our practice where we don't get K2 rampantly easily, patient is also very intimidated. Let them start with D, magnesium, zinc, omega-3. Start with this. If you give them too big a prescription, okay, they will stop. They will not come to you. Take it from me. They just come sporadically. Only there are few who will come to you. Most of them want a practical one. Compliance, compliance of the prescription of methodology is important. So I do give K2. I don't say that, but I don't start it step one. Unless the patient is showing hypercalcemia in the first report. I don't do that. I don't give K2 on step one. Okay. Second test, when they come to me with ionized calcium, then I decide. Many times they don't just need it. They don't need it at all. Okay. Unless the vitamin D is in, the hypercalcemia happens, or it is towards the upper side. Means if the ionized calcium range is from 1.16 to 1.33, the moment I see reports of 1.28, 1.29, which is near 1.33, I will add K2. But I will not give K2 to a patient who is on the lower side, 1.16. Or there are patients who are lower than 1.16 in India. I see patients 0.98, 1.0. Why should I give them K2? You understand? So it's important. We are anyways monitoring the ionized calcium, no? Let that be also a deciding factor. And yes, if somebody has history of nephrocalcinosis, then I'm more alert and about K2. Okay. Selenium is important for skin health, hair health, and that is also a very powerful, what should I say, free radical antioxidant. So that's also a part of the protocol. Okay. It works on the glutathione cycle. It's important. We do give selenium, but friends, selenium, after a couple of months, I've seen we have to reduce the dose because then, say for example, in a patient with psoriasis, yeah, it's also substrate for thyroid hormone formation, selenium, okay? So we do give it, say for example, commonly preparations have 100 to 200 micrograms of selenium. There are some with lesser, 40, 50 also. So the starting dose is, adults is usually 200 micrograms. There are preparations, 100, 200, we give it. But after a couple of months, 2-3 months, I make it alternate day. Why? Because they start complaining of hair loss. Too much of selenium can also be problematic. Okay, so then we reduce it, and after 2 to 3 months of giving it daily, but we continue. So finally, every supplement continues, but there are certain whom we reduce. Like for example, B12. If there's a B12 deficiency, initially we'll give it on a daily basis. But once the levels are okay, we say, okay, continue, but take it thrice a week. But how can we stop? It's food again. But you don't have to overload. So the patients are also happy. This is alternate. This is alternate, and they don't need excess. But this is how I sort of progress with that, whether it is selenium, whether it is B12. Now, friends, whatever we take, like you rightly have asked, gut. If the gut is not healthy, how will I absorb? How will I assimilate? How will the things go on inside me? So, two things I will cover up now. One is gut cleansing, the way I do it, and a little bit about lectins in food. Okay. Lectins. Lectins are natural proteins which are present in some food items. particularly in the shell of pulses, beans, grains. Okay. So like, for example, you take, like in India, in general, pulses are legumes and pulses are very important part of our diet. Dal that we call dals and all, right? So the dal which has a cover will have more lectins than dal which is not having a cover. Okay, chana dal, chana with a shell versus plain chana. So lectin will be more in chana. The beans we eat, the red beans that we eat, the cow beans, the what do you call them? White beans, with a shell, lobia. In Maharashtra we call it choli, right? Now, all these are shelled. The black ones, the masoor dal has a black shell. The urad dal, all the black dals, the black shell ones. So all the chilkas have lectins. And these lectins are irritating to the gut and they can trigger an autoimmune response. They are given by nature to the shell to protect the seed so that whenever you sow it, the plant comes out. But they are tough to digest. So in the initial phase of treatment, I limit lectins in my patient. So I tell them, if you take whole grain, whole pulses and legumes, sprout them. Sprout and cook, the lectins are reduced or gone. And the dals and all should be soaked well. The water should be drained out a couple of times before cooking so that the lectins are washed out. These are simple principles to see that our diet becomes less immunogenic and more gut friendly. Okay, so lectins is important and it's more in the shells of many things. So vegetarian world doesn't mean that everything is good in vegetarian world. We have to see for the patient what type of patient I'm dealing with. Okay, so sprouted is perfectly fine. Sprout your moong dal, sprout your matki, sprout your chana dal, and then cook it. It's fine. Lectins are gone, right? So lectins become important. Soya, yeah, which are the other things which contain lectins? Whole beans, whole legumes, peanuts. So peanuts limitation. Soya bean, Many people put soya bean in the wheat flour before they grind it. So I say, please avoid it for some time. Okay. So lectin causes issues in the beginning and later once they start getting better, it can definitely, when the gut gets better, I told you my aim is they should eat everything without getting affected. I was one of them. There was a time when I would take a bagan, eggplant, and I would get itchy on my skin. Any food having soybean or these lectin containing stuff, I would get a patch on my forearm. It was amazing, right? I would respond to color in fabrics. Red color I'll wear, my body will get hives, urticaria. Such a sensitive system I had, my immune system. Today I can eat everything, okay? Today I can wear red color because internal mechanisms have been corrected and the fort has been strengthened with vitamin D. So lectins also create the leaky gut. That's why we limit it. Leaky gut. So they make the problem. So how do we avoid problems with lectins? Prefer without the cover, soak the lectins well, throw the water, cook and eat. And then, yes, I forgot, please add ginger and all, and add a dash of ghee. Our ancient, what should I say, techniques of food eating were healthy. Little ghee added to the dal makes it easily digestible, better digestible, and sprout rather than taking them whole. Now, finally, friends, treating the common infections in the gut. When we talk of gut health, we may talk of giving all the wonderful supplements for the gut, probiotics, sure, very important. But if the gut has infections, like let me compare it to why did I say it's a garden? See, when you want flowers in a garden, you have to remove the weeds, isn't it? If you just plant all these beautiful flowers with all the weeds around, these flowers will not come. Same thing happens in our gut. I feel that when we are giving all the good things to the gut, anything, no, I don't want to take any names, all the good things commonly spoken about, but there are weeds in my gut. Weeds are the very common infestations there, which may be quiet otherwise because our gut has millions of microbes. But when my immune system is compromised, my gut, there will be overreactivity to many of those commensals there who are sitting quietly otherwise. They are quiet, but now they suddenly become active because my immune system is hyperreactive. So we have to deal with those with some medicines. And now they are becoming a part of many treatment methodologies. Like, for example, I was discussing with even Dr. Coimbra. He says that sometimes we have to give antifungals for better results because Candida is a common infection. We have to treat these infections in people. Results get better. So what I do, I'm going to share with you right away. I want to remove the weeds. So all my patients of autoimmunity now, you can say for the last 3.5 years, I've started treating the common infections on day one. It's a part of my protocol. I don't want to prove it. I don't want to send them for expensive tests that show me that you have candida. Show me that you have H. pylori. Array, we all have them. There are 6 meter long gut cannot be checked with one sample. Cannot be checked with one sample or one view with an endoscopy or colonoscopy. I don't want to traumatize. I would rather treat. I've been trained by my senior doctors when I was in medical school 40 years back. Be a clinician first. See the symptoms and try to treat rather than only going for test. So, what are the weeds commonly in the gut? Amoebas, which you know. Don't we give antiamoebics to children? Immediately, they are teething, but they get loose motions. We give a small course of antiamoebic. When they can have amoebas, why can't we have, right? So, amoebas, parasites, protozoas, bacteria, candida, I just mentioned, yeast, and viruses. Viruses are there. Now, after COVID, which we all have gone through, vaccinated, unvaccinated, we have gone through that environment. Okay. Even those with vaccines, like even I had to take the vaccine, and I'm not feeling bad about it, but my vitamin D was good always. So I presume the vaccine reaction in my body was a balanced one because we are seeing problems with vaccination, and especially hyperactive immune reactions in people post-COVID phase. Now, this so-called virus, right? It has given issues and we need to treat them. So I use a lot of ivermectin, a medicine that is banned the West. Ivermectin is a beautiful molecule, beautiful, and it hardly has side effects. Very safe to give. A small course of ivermectin will do good to my patient. Not only COVID, vaccine, nothing. In general, there are so many other viruses, so many other parasites we need to deal with in the gut. Parasites, I added. So I use a lot of ivermectin. In fact, I use it for all my autoimmune patients now with time. Well, luckily in India, we have, I know the products, but I see them getting it in other countries too. Unless it has to go through a system where you need a prescription, they organize. I tell my patients, like patients who come to me from the West, beforehand, I tell them, I'm going to use these medicines. You will have to arrange them. Don't tell me later you wrote it and I could not get it. I'm telling you right away before you start with me, because my intention is good for sure. Okay, so how do I do it? Antiprotozoal. Hey, we have lovely combinations of onidazole, ofloxacin nowadays available. Yeah, O2, Normet, Orneo. It's a combination which we use for amoebic infection in the gut. Hey man, give a 5-day course to your patients. It's good. You're removing the weed. Nothing wrong in giving that 5 days. Okay. Where is it? Antifungal. I use itraconazole. I use fluconazole. And you don't have to give it in very high dose. Fluconazole, depending upon body weight. Initially for daily for 3 to 5 days, and then once a week for 6 to 8 weeks. Itraconazole, same 100 to 200 milligram. This I use daily for 10 to 15 days for patient, and done. Stop. You don't have to give it lifelong. Although there are some cases who have clear-cut viral things, you see, you can give it longer. In fact, dermatologists also give it to psoriatic patients. I have seen anti-fungals being given for gut infections, which is very nice. It's good to see these things being used even by functional medicine doctors. It's needed. It's needed. Okay. And then, as I told you, the ivermectin. I take history of COVID time with every patient and give ivermectin. Initially, I gave it daily for 3 days. Then I started giving daily for 5 days, and then once a week for 4 weeks. And now to almost all my autoimmune patients, I give it BD, 12 milligrams strength for 3 days, for 3 consecutive weeks, like Monday, Tuesday, Wednesday, Monday, Tuesday, Wednesday, Monday, Tuesday, Wednesday. And if these things are not available in a particular country, place, whatever is available, take that. Some part of the infection, take care of it. Sometimes they don't need too much of gut is pretty good. You don't want to give 5 days. There's a single day preparation called secitnazole. And then doxycycline is another great gut, or let us say a very good antibacterial. In fact, doxycycline has been found to correct many immune mechanisms in rheumatoid arthritis also. So 15 days course of doxy has been studied in rheumatoid arthritis without thinking of infection only. So doxycycline is another one I use a lot. Okay. And then depending on somebody, a skin patient, you can see a lot of redness, a lot of inflammation. I don't mind giving them a 5-day course of cefixime or something at that time needed to deal with the infection. Because this infection is going to keep the immune system up all the time. Up all the time. So finally, we want to treat the cause of the problem. Okay. And of course, albendazole is there for deworming. If I'm giving ivermectin, I don't use albendazole because ivermectin is also a beautiful deworming antiparasitic agent. Okay. It's a wonderful molecule. So friends, I would like to show you some cases now. All right. Give me a moment. Do we give it together? Good question. Good question. Do we give it together? Give me a second. Let me come on screen first. I'm on screen, I think. Okay. So we don't give it all together. I don't do it that way. I give it one after the other so that the patient is also comfortable. And if they want to have a gap of 1 or 2 days between each 5 days, fine. Of course, the antifungal will be once a week. That's not a problem. And most of them, they take it. Okay. So I don't give it all together. FAQ, yes, I will. I've already shared on the group. I'll do it again today. Yeah, I shared yesterday FAQ. Please look into your group. I've shared it last night. 4 things I shared last night. 2 papers, 3 papers, and 1 FAQ. Anyways, I can always do it again. All right, let me share with you now through the cases, please, friends, because that will answer many of your questions. Give me a moment. I hope I have opened the present. Oh my God. I'll have to stop the Zoom recording to open that. Give me a moment. Give me a second, please. In the meanwhile, Vidya, you can just filter through the questions. Okay.
Okay, Dr. Renu.
Yeah.
You said change dose based on clinical first. PTH just a guide. Do we use the PISA questionnaire objectively instead of subjective assessment?
Both are needed. Both are needed. We'll see through the cases. Let's see. You know what? Nothing beats practical. So that's why I made this case presentation for you. I could have stopped my talk today here. Friends, I could have, but no. Let me share it through the cases because that's a beautiful way to learn how practically things can be applied. Just give me a second. I should have, my bad. I should have done this before. Sorry. Just opening the presentation. Just give me a moment. All right. So let me get back to Zoom. Thank you for your encouraging compliments. This computer. Okay, dear. So now let me do the slide sharing. Yeah. Okay. Visible? Yeah. Okay.
Yes, we can
So
see.
friends, let me share with you what strategy I've made to simplify this work with my experience. And this I published in my paper this time. How do I stratify the dose? And this is for patients with in the category, common category of psoriasis, rheumatoid, gut, and all those problems. And even for MS, I begin with this only, and then later I increase their dose. Unless there is a, okay, MS I'll deal with later. So if a patient's body weight is 60 to 75 kilogram approximately, I will start with 30,000 IUs per day. mindset matters. Suppose he's a very scared, very darawa type of a patient, then I'll say, okay, start lower. And how do I do this 30,000 in my country? I'll tell you the same 60,000, the same nano bottle. I tell them take roughly half today, half tomorrow, finish. Okay. Or we get tablet preparations in our country, 60,000. Many preparations are there. Tayo is there, Calcigen D3 is there. So many companies make tablet. So half, it's a breakable tablet. Half means 30,000. That's one way of taking it. Okay. And otherwise, if remote area is not possible, this same gel cap, which I showed you, which is 60,000, I say, okay, take one alternate day. Because this one you cannot break. So take one alternate day if it is 60,000. Okay, right? So that makes it 30,000. If somebody is more in weight, 75 kg plus, the starting dose, I keep it 40. Now, how do I make it 40? Because we don't get 10 in India. Okay. So I say half, half, full. Half, half, full. Funny, no? But this is what I've developed. Half, half, full means 2 days take half, third day take full. You average it out, it is 40. Got it? Yeah. Otherwise, if in your country you have 10,000, like there are many preparations of 10,000, you can, sorry, I should have shown it. You can get it online. So this is I hope you can see my picture on the screen. Okay, I'll show it to you later. There are many 10,000s. Online companies are there which supply entire globe. Like there is one that I showed you, Healthy Origins, name of a company. Now it was very popular. Orange colored bottles are there, NOW. They supply every country. They have a 10,000. And there are some companies in India also which have come up like Mayers, Mayers. It's with a collaboration. You get 10,000 there. You can order that online. Okay, so there are so many companies. 10,000 you can get online easily. So that goes 3 caps daily for 30,000, 4 caps daily for 40,000. And there's another great product of drops, which I told you, which we don't get in India. I hope you can see it. Yeah, now this is 2,000 IU per drop vitamin D from a company called Life Extension. Very easily available online. Life Extension, 2,000 IUs per day. So you take 10 drops, it is 20,000. 15 drops, 30,000. Just tell the patient, pour it in a spoon and drink it. This is a it's a good product. 2,000 IU per drop. Okay. It's interesting. 1 drop will be enough for a child rather than giving 1 ml, 5 ml types. So this can be easily titrated. Now this is Life Extension. This is a little sweetish in taste. There is a company which makes the same drop, same concentration, unsweetened. And that is Nutrasal, Nutrasal, Micro D3 from Nutrasal, online. And that is the one I tell them to mix in the oil and apply in the West because this is sweet. I told you, you can mix drops. Nutrasal, Ultra D3 by Nutrasal. Sorry, Micro D3. Micro D3 from Nutrasal, mixed in oil to apply to skin, or you can even take orally in the drop format. Okay, so these are some of the preparations. Now, even amongst nano that we have in our country, they are sweet, Arakitol Nano, Dexel, Depura, so many companies are there. Uprise D3 has made an unsweetened version of this, Uprise D3, which is very commonly known. Patients also know that name. So that is unsweetened one, just for your information. So anyways, whatever you'd have to titrate the dose based on what you have availability. Now, if you have a preparation of 1,000 IUs, hey, will you give 30 capsules to give 30,000? Right? So this is what you have to work upon. Like patients from Middle East, they get 25,000. Fine, fair enough. 25 plus 5. So you have to work it out. There's one more way of working out doses. Like yesterday only I did for a patient from West Africa who got a 50,000 preparation, a French company preparation of 50,000. I wanted to give him 40,000. Okay. So I said, take one daily, take it 6 days a week. So it is 50,000. If you reduce one day, the amount comes to near 40,000. So these are things we have to work out. I hope you get the point. So anyways, this is how I start. Now, if the first check of vitamin D is very important. If the levels are very low on the start, hey, this 30,000 also will be low to start with, because this point number one begins when the levels are reasonably good. The compartment number one has been dealt with. Then comes this 30,000 daily, compartment number two. So if somebody is coming to me with very low levels of vitamin D on the start, let us say less than 20, hey, I'm going to give that injectable 6 lakh IUs. If not injection, I told you yesterday, even taking it orally works. Or I tell them, take your 60,000 one daily for 10 days. There is no rush, no emergency that you have to take an injection. No, Baba, I don't care about that. Okay, so take this daily for 10 days. You're getting 6 lakh IUs. It's like a car on the reserve. You gave the petrol, bought it up, and then you start 30,000 IUs daily. You understand? Okay. So if somebody has a level of less than 20, I made it a norm. We give them that 6 lakh units over 10 days. And if it is 20 to 29, we give half the dose over 5 days, sometimes 7 days, depend upon the clinical decision at that time. And then embark upon compartment number 2. And before starting, we have checked the PTH, ionized calcium, everything, and we have a record of it. And then we call them after 2 months for a repeat test with the results. I write it on the prescription. Please do this test and fix appointment after 2 months. If somebody has hypercalcemia at the start or the PTH was very low, I may do the test after 1 month. And there are some patients who are very anxious. Check it after 1 month. I have no problem. You want to check it? I have no problem. All right. So we have to decide based upon the patient. Then the dosing is adjusted according to clinical response and lab parameters, which you know it's PTH. And is there change? For example, you'll see in the cases, there is no change happening, no improvement. And the PTH is almost the same or little come down, we will increase the dose. But if the clinical response is good and the PTH is not touching the baseline, we will continue the same dose. We will not increase it. We will continue the same dose for another 2-3 months maybe. Check the reports again and then start reducing. How? I'll show you. Down titration was performed if ionized calcium exceeded 1.33 or if PTH fell below 12. Escalation was considered in case of suboptimal clinical improvement and insufficient PTH suppression. I think this is a very good statement, clear statement. Okay, this is all published in my paper. Upon achieving improvement, doses were tapered by 10,000 to 15,000 per month at that rate. Okay, to determine the lowest effective. Now, effective will be on the clinical response. There is no other way. Here, PTH has no role because you're not increasing the dose. PTH plays a role when you are increasing, or let us say trying to see if whatever dose, high dose you're giving, it has not further led to PTH coming down. When you're reducing the dose, we don't insist unless the patient is doing it. We have no problem with that. Okay. So I think this slide has given you a picture of how I proceed. This is one of my papers, case studies. Yeah. This was 2022. It started with 6 cases I reported. And now the last one, which I've shared with you, is published 2 months back, 95 cases of psoriasis. So in these 6 cases, we gave so much dose. I would rather show you the case. And we did all the monitoring with PASI scoring and visual analog scale and everything. I would rather show you the case. Give me a moment. Yeah, so this is one lady. Before treatment, a palmoplantar. After treatment, I'll just show you. I made a chart to make things easy to understand. When she came to me, her vitamin D was 45. Good, right? Not low. PTH was, now you can see, 37.5. Fine. It doesn't mean that why it is not high. It's not like that. It's a relative thing we are trying to see. So it is 37. Fine. Cool. Ionized calcium, 1.27. Started on 30K. First visit, third means, when she came to me, second time actually. I should have kept this 0, but okay. First visit, second visit, third visit. Third visit, her PTH was so much. Can you imagine? She was showing improvement. Third, and every visit is usually after 2 months, whether it's online or whether it's in the clinic, approximately 2 months. Calcium maintained. She was showing improvement and she had taken it for 4 months. Okay. This is a very early, she had come to me, one of my very early patients. 20K, kar diya. And how did I make it 20K? Half, half, zero. Half, half, zero. Half, half, zero. Ho gaya 20. Average it out. Because we don't have 10K easily available. And she was a patient from a remote city in Tamil Nadu. Okay. She had improved 80% in 4 months. Other follow-up, I further reduced it to, hey, don't make markings, please. 15K. 100%, almost 100% improved. And she's even today, 7 years down the lane, maintained well on 60,000 per week. Okay. Abhi 6 years ho gaya isko. You want me to again remove the marking, use the rubber. Hey, I did it. Okay. So this is another lady patient. Yeah, she was from the UAE. You can see the extensive plaque psoriasis on her entire body. She also responded very well. And she's still under follow-up and doing very good 7 years down the lane. One sec. Yeah. Now this is her chart. She came with a vitamin D of 11. Okay. PTH 65. Calcium. Now this is a different unit in that country. And this is the range you can see. I put her on K because it was nearing the upper limit. No, I'm so sorry, not this one. Sorry. Okay, so I had to give her that 6 lakh because the level was very low first and then put her on 30K daily. First follow-up, PTH was 37.5. Calcium, now this is a different lab. She had actually come to India. She got it checked here. It was 1.28. I gave her K2. I remember I gave her K2. She had history of family history as well, but I didn't give her on the first go. I gave her in the second visit. D, I reduced it to 25K. How do I make it 25K? Well, if you're using 10K, suppose you're taking 10K tablets. So 1 day 3, 1 day 2. 1 day 3, 1 day 2 becomes 25K. And if you're using the 60K in India, how to make it 25K? Take half daily, 6 days a week, not 7 days a week. It is around 25. You can see mathematics. Okay. Interesting, huh? Fun to do all these things, by the way. And I had no mentor to tell me how to do that in your country. I just did it myself. I worked out my ways. Huh? Because everything is workable. I believe in that. Fine, move on. Then next visit, fourth visit, PTH was 13. It has come down to the lower limit, further reduced to 20K. Finally, she's doing pretty good and she's maintaining on 20K. Because the moment she says I reduce that, I go on a weekly dose, my skin starts getting itchy. So she's taking 20K, half of zero, but now she's purchased a 10K and she takes 2 daily like me. Her remission is not 1 year, it's much more than that. This is an old slide. This lady is a cardiac anesthetist, one of my very early patients, very bad, not only plantar, very thick, scaly skins. We have worked together when I was in charge of ICU in a major hospital in Pune. She's a cardiac anesthetist. She responded too good. And we doctors want to know. So we did all the vitamin D levels she wanted to do. I said, please do it. So she came with a level of 21, as you can see. PTH was 113. High, very high. Ionized calcium high. So again, given the bolus, given 30K. Next visit, she was 150 already. Everybody doesn't come to 150, but she came. It's okay. She was a thin lady, by the way. She is a thin lady. PTH had come down to 83. Now you see this case. It's still above 65. Still above 65. Calcium was 1.33. K2 started. Vitamin D reduced to half the dose. Even if she had not shown improvement, I would have reduced the vitamin D because of the calcium. And at this very beginning time, I was scared of giving too much vitamin D. Now, probably I would have continued given K2 and if the response is not there, but she already showed a response. So I made it 50%. Next visit, D was more than 150 because commonly labs don't check the levels above 150. They just give a report more than 150. How much it is, Ram Jane, we don't know. PTH had come down to 58, but still see how much it is still away from the lower limit. But she did so well, almost completely cleared. So again, she is on once a week dose, going on for years. well controlled, and she checks her reports once a year, and very sincerely she will send them to me. And her PTH is always on the upper side of normal. She has that tendency. She did check for any nodule in the parathyroid. There's nothing out there. That is a tendency. Now, this lady was tough to treat, not only because of the look of the problem, but because of the vitamin D resistance she had. A lady with whole body, this eczematous psoriasis on the hands, feet, you can see she is completely okay now. Hands before, now I've hidden her eyes, her face is completely normal. She was a lady who could not afford treatment, so I didn't. I just said, I'll give you all my advice. You just spend your money on taking your medications. She came with a D level of 9. Sad. PTH 52. Calcium 1.1. See, it's on the lower side. Okay. Bolus followed by 30K. Next visit, you can see PTH 35. It has improved. It has come down. Calcium on the lower side. I increased her D because there was no improvement. Nil improvement in 2 months. So I made it 45K. How did I do it? Alternate day, half full, half full, half full of 60K. I could have made it 40K. You may ask me. I could have done 40K. But well, that time I did 45K. It's okay. Her skin was really bad. And that was the time I was not using these gut medicines. I think if I had given those antiviral, antiamoebic, maybe she would have required less vitamin D. I don't know. Anyway, so now this was the picture. So I increased the D. Third visit, fourth visit, PTH is still unsuppressed, 29, calcium on the lower side. And I didn't give her K2, friends. It was not available that time and she had no money. This is a patient managed without K2. Okay. Then I started reducing her dose, slowly, because she started showing improvement, 40, 30, 20. She's now maintained on 20. Her PTH in this range, calcium maintained, no K2 given. Lack of availability, crisis of money. Take vitamin D, take what is important. I gave her magnesium, selenium, zinc and all, but doing very well. A doctor with whole body psoriasis who was a non-believer of vitamin D, okay, non-believer. He was taking vitamin D, compartment 1, but non-believer of vitamin D to be able to, or let me say non-believer of high dose D or scared of high dose D is the word. He was not non-believer, he was scared. He had that mindset. So he came with 61 because he was taking 60,000 per week. As such, he was taking PTH 24, not high, not very low, but had to be, but my yardstick for managing. Calcium 1.1, started on 30K, bolus not needed. Next visit, 160. PTH, see now this PTH has come down, 7.76. Calcium, lower side, well maintained. I reduced the dose. And plus he was showing some improvement. I reduced from 30, made it 20. Repeat, 60K, half of zero, half of zero. Okay. Next visit he came, the lab, they give more than. So it was more than 100. We don't know what. And since I reduced the dose, his PTH now came up to 18. Calcium within range, 15K. He did well. He was doing well. Okay, now he stopped. A case who said, no, I don't need it anymore. I told you, he stopped taking this 15K. He went back to a break and he said, I don't need it. I'll take a break of a few months. His skin problem came again. I think it took 1 year or so. He came back again. That time his levels were 71. Not bad. PTH 19. Started him again on 30K. So he's the one who keeps stopping, restarting. There are patients like that. But now I think he takes, not had a follow-up for a long time, but he's taking at least once a week. Things are in control. Should not be stopped. This is a very interesting case. I have to tell you, a very bold lady from the United States. An amazing friend she has become. So she came to me with psoriasis, palmoplantar, you can see in the legs, okay, in the feet. Now they're all completely gone. In fact, I have this is an old picture of completely gone. Now it's beautiful. It's a beautiful picture. Listen to her story. She started with 39 vitamin D. PTH 26. Now you see, her PTH should have been more. Now she is a patient of hypothyroidism. She was on thyroid hormone replacement. So I presume she also has autoimmune hypoparathyroidism. So from the start, her PTH was low. But her PTH never came down to very less. You know how much dose of vitamin D she went up to? 80,000. Wait, listen to the story. Okay. But it never came down very low because of the high degree of vitamin D resistance, hypothyroidism, skin, diabetic. Uh, she was an obese, and she was obese also. Anyway, so now a PTH there, that lab checking was a different unit. On the higher side, she was put on K2 from day one. And considering her weight, we started around 40,000. Cutting the story short, just see that her vitamin D levels, she kept checking. You know, there 256, 220. We have all these reports. I tell my patients, share the reports by email. So I have all the records. And as I told you, I don't treat patients without them signing a consent form, which I'm going to share today on screen with you on your group. Because I'm keeping, and they're showing these reports. Tomorrow, anybody can take me into a hot soup. Okay. But I have my reasons to justify. And now there are many publications that are showing high dose D is not a problem. And I must quote Dr. Coimbra here. There is a Helsinki Declaration. You can go and Google and see Helsinki. HEL, it's a city in the Scandinavian countries, Helsinki Declaration, which says that if the patient is approaching you and you're used for treatment and he wants it, he or she wants it, and you are trying an unconventional method, you can do it because the patient has come to you. That is the Helsinki Declaration. So I see that the patient has come to me. I have their email. I want to take treatment, consent form, reports, you know. So this is till this work gets properly, totally established. We have to take care. So this lady, you can see how the vitamin D levels were up. PTH never came down, very down. Ionized calcium's always within range. K2, magnesium, everything on. And vitamin D dose, you know what? I took her up to 60K, honestly, friends. 60K. She on her own, she didn't tell me that time. She increased because you know what? There is little more awareness of high dose D there in the West through the net, knowledge, whatever, Facebook. She took 70K. She took 80K on her own daily. And then after the next one, you know, my skin is much better than before. And she told me I've taken 80K. We brought it down. So she is, can you believe it? She's on a maintenance dose of 50, 40 to 50K she needs it to keep her things in check. I have a beautiful video from her as a feedback. I don't want to say I praise me. I say praise vitamin D. And talk about the high doses that you have taken. Let it be there in a video format. If you want, I can share all that stuff with you. Okay? A no success story. There are many of that type as well. Don't think everything is a success. A gentleman with plaque psoriasis not responding. And I've seen the non-responders are usually the ones who've taken or who are taking immunosuppressive modulator, let's say the medications. Many times we don't know what the other pathies are also giving them. We don't know. Anyways, I tell them not to stop it, as I told you, even any other pathy that is going on, till vitamin D starts showing action. Hey, mute yourself, Vidya. I'm muting you, Vidya. Sorry for that, but I have to. Now, this gentleman was a chronic alcoholic. He could not live without alcohol. That's why I show this case. And probably that was one reason he was not responding. And Dr. Kundra says, alcohol, smoking, you need to stop for all these things. They keep the immune system very highly up. So he was a non-responder. And what I did for him, you know, when he was not responding to all the deep protocols, I added a touch of methotrexate along with vitamin D. I didn't stop it. A touch of methotrexate means normally we would give maybe 15 milligram per week. I said start, because he was obese. I said start with 10. Then I made it 7.5 eventually. And I tried to make it less very fast. I don't want it to be a lifelong affair. A touch to probably get that little. And I don't use very heavy immunos. I use only folitrax, methotrexate if needed. And if the patient says yes. Okay. So he is doing okay. He has improved, you can say 30 to 40%, but he doesn't change his habits also. What to do? So at the moment, he's only on the vitamin D. Call it a maintenance dose. He takes 30,000 daily and alcohol. Let's move on from skin. Rheumatoid arthritis, urticaria patients are also. Now, only thing is with this, I have no picture to demonstrate to you results. but I have people who responded here. The earlier it is given, the better are the results. I keep saying it on and off, on and off. Started with 14, PTH 23. Friends, give me 10, 15 minutes more. Calcium, you can see range. Started him on load bolus plus 30K. His RA factor was 169 when he started. He's a case which responded well. He had urticaria. He had borderline hypothyroid. His borderline hypothyroidism got corrected with only vitamin D. He did not need to take thyroid hormone replacement. Just to quote that. Rheumatoid arthritis improved very well. He's a very popular yoga teacher, by the way, who runs beautiful online classes. There was a time when he could not perform yoga because of his joint pains, and now he does everything. He takes vitamin D every day. His levels had also gone up. PTH is coming down, blah, blah, blah. He's maintaining on 10 to 15K daily basis, doing well. And even his problem, this is not immediately after 1 year, but his RA factors have also touched normal. We do see that. But there are patients whose RA factors don't touch the normal, but they do well. They do well. They come off their, what should I say, the medications, and they continue with vitamin D. And friends, please at this juncture note, there is a category of RA which is called as seronegative rheumatoid arthritis. Means RA factor is negative, but they have RA. And trust me, they are more difficult to treat than those who are RA positive. So we don't know everything. Everything does not have a marker. Our body will always remain a mystery. We'll keep finding few things, things will move on. So don't just think that parameters have to normalize to become okay. They take time. Yeah, thankful to her. She's a patient of mine who came to me with myasthenia gravis, a scientist, beautiful friend again now. She had ptosis. She was already on immunomodulator medications, completely gone, ptosis, doing very well, and she's off all those medications. It took me 2 years to bring her to this phase. And now she's on a maintenance dose, okay? Came with vitamin D27, PTH 67. I don't think we'll deal with too many cases of myasthenia gravis unless we are in the field of neurology. But I must make it here in these patients, we have to be careful about magnesium. We don't give them too much magnesium to myasthenia gravis because their symptom is muscles, the acetylcholine receptors, muscles go weak, and sometimes magnesium problems. So we give very low intensity, or sometimes we have to stop it also. Possible. Just note this point. If you happen to deal with a myasthenia, Dr. Coimbra says give low dose, and this lady I was giving a low dose, half tablet rather than full tablet. PTH was 67, blah, blah, blah. We started vitamin D. She did better. As I told you, 2 years, she's off the azathioprine and the steroids that she was taking. Okay. She needs 30,000 to maintain, by the way. She needs the higher dose. Multiple sclerosis, so many patients. I have reports to tell you. This is a girl came with, can you believe, MS patient coming with vitamin D level of 50. And she was taking medication. She was on Lefno. PTH 116, calcium lower side, vitamin D. I had to take her up to 60,000 daily. Right? You can see that. PTH was not getting suppressed. Her PTHs are always high, always high. She did very well. She came into remission to a state that now she has a baby. She became pregnant. Childbirth happened after recovering from MS. Throughout her pregnancy, we continued vitamin D. I told her I want to tie up with your obstetrician so that we see that you don't land up into hypercalcemia, because calcium is prescribed every day in pregnancy. And luckily her obstetrician was a very open-minded person. We've become very good friends now. And in coordination, monitoring her ionized calcium, she gave very little calcium and did not too much. And we monitored it all through because her calciums were always on the lower side. She never had hypercalcemia. And we maintained vitamin D throughout pregnancy. And she's happy to share the picture of her baby with herself, who's a happy mother after, going through MS. She takes 40K daily now. And only thing is, I keep telling her, let's do an MRI to see your plaques have gone. She doesn't want to do it. Can't force her. I want to see her MRI now. This doctor patient of mine, he did his MRI and I'll show it to you. He's a story of not just success, but it's like an award or a reward to the work that has gone behind this. He came with a vitamin D level of 92. And he's a doctor. At that time, he was doing his MD in medicine. Okay. Yeah. PTH 32, despite such high, sorry, vitamin D high, PTH within range, calcium low. Vitamin D started, he had eye symptoms, headache, symptoms of optic neuritis. His levels crossed 200. See, despite crossing 200, PTH has come down, but it is not super low. It's not zero, it's not one, it's not two, which is theoretically expected to happen. No, it didn't happen. So anyways, we took him up to 40, 50K, and he was not, why I mentioned here, one brand of vitamin D was not suiting him. He changed the brand and his headaches went away. This can also happen. We can be reactive to anything. So anyways, he did very well. His all symptoms are gone, and his MRI showed disappearance of plaques, which were visible earlier in the neck. If you can see, the report says previously described abnormal signal intensity are not seen, suggestive of resolution. So he's a story which we can show through his MRI reports. And more than the success story, this doctor has joined and now completed DM neurology. It is so gratifying. He says, he did DM neurology so that he feels he's an MS patient and he should be able to utilize his knowledge, his experience of even vitamin D for so many patients. And through him, I see so many multiple sclerosis patients getting the benefit of vitamin D. So friends, I think by now you can see that there is no fixed dose for a particular disease. Dose varies based on the degree of vitamin D resistance. And the more number of organs involved, more is the dose requirement. Like this lady, that anesthetist, she responded well to 30K. I have another patient here. He's a farmer who came to me with hands. He was so, he just gave me, doctor, anything, I'll be fine. I just gave him, he was one of my first patients. I just gave him weekly dose and his problem went away. He was one of the very trusting minds. This gentleman, oh my God, he needed for this only limited psoriasis, not too much, only on the elbows and knees, 60,000 daily to be able to come out of it. And he takes a maintenance of 30,000 daily even now for so many years. He needed it, although the area of involvement was so low. So his vitamin D resistance was high. Yeah, this is the gentleman. We had to go up to 60K for 6 months to be able to bring him out of the small patches on the elbows and all. The more the duration of autoimmunity, cellular death if it has occurred, less chances of reversing. I explained this very adequately to you all yesterday. Axonal degeneration, no response. Only demyelination correction happens. Psoriasis, better response. Vitiligo, poor response. Okay. However, we still do the treatment because the process of autoimmunity can be kept in control and the disease progression can be controlled. I have patients who have not responded well in MS. He's one of them. In fact, a very, very nice gentleman from Delhi started with 67. Vitamin D's always went above 150. PTHs, you can see, maintained, never going very low. We have to take him to 70K. Nothing was helping him. 21 years of MS. So now he's on a maintenance dose of 30K and he says, I'm happy with that. At least I have kept my things controlled from progressing. 30K. More the duration, less chances of reversing. This is one patient of that category, MS patient. And she came on a wheelchair. She's from UAE. She once came to Mumbai for some work. So she said, I want to meet you. And I said, how will you come to Pune? I had to go for a conference. It was an ozone conference. So I called her there and I met her there during the conference, ozone therapy conference itself. Now, why I've shown you this lady's picture? Not because I want to show you with me. No. We could do nothing for her MS. Nothing. We could not bring any improvement. But, she was a hyperthyroid, as I told you. I didn't realize her hypothyroidism has got corrected with the treatment. She's off the medications for hypothyroidism. MS remains because it's permanent damage to the nerves. She has hardly any power in her legs. We just cannot do anything where the cell death has happened. But a thyroid problem has been brought in control. She's off her neomercazole. I've not put the thyroid reports here. And a TSH. This is when she was on therapy. Now she's off therapy and her reports come between the normal range. And we did not need to give her too much vitamin D for that maintenance. So 15K daily, 20K daily in the beginning, that we could achieve the thyroid correction. Another gentleman who came to me with psoriasis only. Coincidentally, his TSH was 0.04. So he was in the hyper toxic range. Did nothing, just gave him vitamin. Nothing means did not give him neomercazole. We gave him vitamin D therapy for his psoriasis, and his TSH automatically has improved to 1.41. Did not have to do anything for. So point is, we are treating the cellular pathology. So autoimmunity can affect any organ. Some organ responds, some organs don't, depending upon the degree of damage. This gentleman, even the skin responded, it was psoriasis, and even his thyroid has responded. But again, he needed more doses than otherwise. This is that child I was telling you with the liver enzymes high and becoming normal. Came for the treatment of her skin problems and has autoimmune hemolytic anemia. Look at the liver function reports. This was her SGOT, SGPT. I told you 4 figures, and this it is now. Interesting. Can you believe it? Vitamin D therapy just given for her skin issues. So it's where vitamin D is very good for the liver. It improves the detoxifying mechanisms to the liver. Then there are certain autoimmune disorders. I'm just showing you different categories which need a longer duration to. Don't think everything will happen in 3 months. Like for example, pigmentation. I myself had LPP, I told you. My LPP, lichen planus pigmentosa, which this gentleman has, mine was in the whole face and whole neck. I will show you my picture if you want to see. It was so bad, huh? So now this gentleman had it. He took 2 years. Even I took 2 years to come out of my issue. And even now, I will say 10% is still there in my neck a bit. But I'm okay with that. It's fine. Even to my patients, I say, if 5-10% remains, be happy. This is a way nature is trying to tell you, don't forget the goodness of nature. Okay, keep sticking on. So this gentleman, took 2 years to come out of this. Only for the pigmentation of the skin. He's a very high-end corporate, okay, globe-trotting. His vitamin D level was 4 when he started. PTH 116. So same policy followed. There was a phase where his PTH is, you can see the decline. The third visit itself, it came from 116 to 15. But we continued with the therapy, slightly lower doses, but continue to a point. 2 years, he's fine, okay? More the number of autoimmune diseases, longer duration to show some result, like this lady of mine, patient of mine. So many problems, psoriasis, lupus, Sjogren's, Hashimoto's. She came to me basically for joint pains because the pain is really a bad symptom, isn't it? You don't care about how your skin looks when you're in pain. Her pain was because of the connective tissue disorder she was having. But this was the look of her skin before and now. This was the look of her joints before and now. So you can see the amount of inflammation she had. So multiple diseases took some time, but doing well. Certain autoimmune disorders need more vitamin D, like I told you, multiple sclerosis. This is a patient of mine from UK, young, very dynamic, high-end IT boss, okay? He was already taking vitamin D. He was on 10K when he came to us, and his levels were 60. PTH checked in UK, different norms, different lab. This is the range. So I always write the range because I can't remember the range for every lab, okay? It was in the range. Calcium, different unit, different range. Started with, from 10, I made it 30, 40, 50, 60, kept increasing. Because, you know, there's one thing I want to highlight here. Dr. Coimbra has taught me, if a patient is going through acute symptoms, say, for example, a patient of MS, optic symptoms, vision affected, it's galloping. Don't worry, give more dose of vitamin D. Don't wait for 2 months. Keep increasing, done, give. Save the vision, save the eye. You can save it and then bring it down. So I did that for Karan, this boy. And just recently I had one dentist coming to me. She had vision symptoms. She was on steroid medications, blah, blah, blah. We gave her all the D. She became okay. But unfortunately, she stopped taking for a few months. Again, her visual symptoms came back. And I had to give her real doses, and 90% of her vision has improved in 1 month's time. Can you believe that? So I can say vitamin D has saved her eyes, because if it becomes permanent, the visual field defects become permanent. Okay, so when there's an acute phase going on, we don't hesitate in galloping the dose of vitamin D up, because you can save the organ. And this is more true with MS, because it's a neurological happening. And eye symptoms are very, very common in the start. Then there are nerve symptoms like paresthesia, hermit sign. They just bend the head and they get shooting pain in the body. That's called hermit sign. That's an acute symptom. We treat with high dose. So this gentleman, increase, we took it up to 1 lakh IUs. Levels were always very high. He did very, very well, and he's still doing very well. And he continues, and he's now on 50,000 IUs daily as a maintenance dose. Every year he comes to India, follow-up going on. Now, we don't need to check everything all the time. And yes, with such patients who are on high dose, we also do the DEXA bone scan. We do all that to see that the bone health is in order. We may need to give bisphonates, like I've given to one patient where the bone scan, because vitamin D in very high doses can be osteoclastic. Osteoblastic means which makes the bone tissue. Osteoclastic means which dissolves the bone tissue. In very high doses, and this usually won't happen with 30,000, 40,000 doses. When the doses are reaching 1 lakh or more. So we look for that, and if it is happening, we have to give bisphonates and all to see that the bone structure is not getting damaged. Exercise matters, weight, he does all that. Weight-bearing exercises, running, jogging, he does everything. We didn't need to do that supplementation for it. So I get such lovely feedbacks from them, from this gentleman, Diwali wish. Thank you, ma'am, for making it possible for me and my family, because they had thought that the whole life will change. This is another she was my first patient of MS, young girl from Mumbai, difficult to walk, very thin built. Her weight must be hardly 50 kilograms. 26 was the level, started again, acute symptoms, galloping. Took her up to, this she did on her own, by the way. I took her up to 80, 90, and then I was not confident. She was my first patient of MS. It was very scary. And I remember at that time, I was scared to deal with her alone, but she was very enthusiastic. And so I did joint consultation with, a doctor from the Coimbra team, so that I'm not making a mistake. We did it together for her, and we took it up to 140. Can you believe it? She has done so well, very well. She was not able to walk. She walks, she joined back work. She's working for an IT company, and now from Mumbai, she shifted to UK. Cold climate, she can tolerate that all despite her past history of MS. A success story. This is her feedback. I can't read it for you. This was her testimonial. So finally, friends, we can see permanent remission in many conditions based on when they come, how many organs, what doses. If not full remission, we do see partial remission, which is equally good. If nothing, we can control the progression, reoccurrence, and occurrence of so many diseases. This is another great paper, which I've already shared with you. Safety data in patients with autoimmune diseases during Coimbra protocol, taking high doses. 319 patients have been seen over 3.5 years taking this dose, no toxicity, and even my paper published shows all that. Okay, so summary. Friends, there is no fixed dose for a particular disease based on vitamin D resistance, and now we can say number of organs involved and the duration of disease. The more the duration, less chances of reversing, but still we do it. However, the process of autoimmunity can be kept in control and disease progression in check. Some brands, if they do not suit, change. Do not hesitate in starting at least a physiological dose of vitamin D, which is, we've already discussed compartment number 1. And even in autoimmune diseases, you can easily take 20,000 daily, even 30,000, nothing goes wrong. There is enough evidence. If you don't want to go beyond 30, do it up to 30. Okay, try that and see. And keep the monitoring on, keep the reports intact, and keep all that in mind. So friends, finally, friends, now you will agree with me. It's not an optional supplement. It is a necessity. And I say that loudly on the International Day of Vitamin D. And I would like to quote Hippocrates, whose oath we take when we qualify as medical doctors. What it says: wherever the art of medicine is loved, there is also a love of humanity. And that is why we have gathered together. Thank you so much for trusting me, vitamin D, and what should I say, and helping take this knowledge practically ahead, because each one of you is a community. Thank you very much. So many hearts. Thank you. Thank you so much. And I'm sure you are dumbstruck right now with all that you have learned, especially if it's the first time for you. It's all right. It's natural. It's natural. Our groups will remain intact. And I would say if you have any query anytime, put it on the group if it is of interest of all. If you want to discuss a case, give full information. Because I see people just come to me, I have a patient of psoriasis, I've given vitamin D, PTH has come down, but there is no response. Hey, what do I do? You have to give full information. Make a table, write the values, D, PTH, what dose. You understand? And then put your question. Then it helps all. And we are always connected. And this movement, D Magic, I look forward to your support too eventually. Let me just give it a structure. And this thing will continue. If anybody else wants to do this program, I think I will repeat it, but not very soon. Maybe after, let me say 6 months, but I will try to do it after 3 to 4 months because I have many, many things on my platter. Too many things which I want to complete. Okay, thank you. Any questions which are, and in case you want to leave, you can because it is 1:30.
Dr.
If any
Renu,
question,
there is
yeah.
so many questions. I have to filter because I think they ask too fast before you do the presentation. So
I know there must be many which must have got answered also. I'm very sure
yes,
about it.
so I think I have to filter.
So you can do it later. Maybe you can do it later and then put up the question on the group if you want to, or you want to do it now. I leave it to you.
I think also maybe there's too long for anybody. Maybe it's better that we do the discussion on whether Indonesian or Indian group.
Okay,
Okay.
I get your point. Maybe
Okay,
what we
because
can
there
also,
is 77, almost 80 questions. So I think it's not enough.
okay. So let them ask it on the group now. Not a
Okay.
bad idea. I think that's a very valid suggestion. Thank you so much. I would
Yes.
suggest that I think many of your questions must have got answered, which have come before that point was discussed. But you can always put it up on the group. Okay. Yeah. Does combining ozone and D3 improve the success? Yes, of course. Ozone is a very good molecule and it does improve. Only thing is psoriasis, local ozone therapy plus minus, it makes the skin very dry. So if you are giving local ozone to the skin, be sure that your patient is lubricating the skin well because the dryness will aggravate the problem. Otherwise, my favorite is rectal ozone. I've done all the ozone therapy. Rectal ozone is the safest and the best, and it works through the gut, liver, amazing. No injections needed. See, it's my personal thing. I prefer things which are non-injection. Okay. So rectal is amazing. And if you are giving all those major, minor, I have no problems. It's an amazing therapy. You can do it. But don't forget vitamin D. That is important. Correct the vitamin D also. I'm sure the other therapies will work better. And Millie is a great friend of mine. Although she's not here, I take this platform to greatly thank her because she has helped expand this family so much. And many of you are from the Ozone Forum. So thank you so much, Millie, if you're hearing me. Okay, so bye to you all, Genti. I know you have lots to say. I know she wanted to share her experience. Maybe, 2 minutes if you can say. I'll be happy to. She's one of my most sincere, what should I say, like Vidya, a representative like Sahara from Indonesia. Go ahead.
Okay, I just want to share like 2 minutes. First of all, thank you so much, Dr. Reno, Dr. Vidya, for giving opportunity for me to share. There is like a few cases that Dr. Reno's been helping me with the psoriasis cases. But there is the two things probably in our experience. The first case was a 14 years old girl with psoriasis. And then
I remember.
we start treating this case with the checking the PTH level and then vitamin D. and ionic calcium, the first 4 months, 80% improvement of her symptoms. And then in my, I have so happy with my results because it's built the confidence, built the level of belief from the parents, the children, also for me myself. And the
Thank you.
second case with the psoriasis and diabetic. So this case, actually, we treated her very good with the PTH level and then ionic calcium and vitamin D with a high dose. And after 4 months, the result is very good. But after that, the patient feel discouraged to have the maintenance dose because the conventional doctor, her internal medicine doctor, discouraged her to take the high dose vitamin D to maintenance her D level with the psoriasis case. So what happened is her skin rash is coming back. And then she came to me again, and then we consult together with Dr. Reno. We have to redid it again, the program for her for the next 2 months, 3 months, monitoring strictly with PTH level. And right now she's doing better. So yeah, this is the 2 cases, and other cases
Thank
maybe
you.
we can do it later. But my words for you, Dr. Renu, thank you so much for giving us more confidence and belief about this
I'm
treatment.
so happy.
And
You're
then
more than welcome.
thank you also for spread the good news toward the medical world around the globe. That is probably
Thank,
from me. Thank you so much.
thank you so much. It's all my pleasure, and I feel privileged to have the support and trust of you all. Thank you so much. Thank you so very much, each and every one of you, because I know somewhere or the other the light has been lit, and it will show the glow will come out in some or the other form. You may not really treat so many autoimmune patients right away, but at least we will keep our other patients healthy, and the light will spread, will move on, because it's pure, it's genuine. What we are doing is genuine despite all the oppositions. Despite, I face it every day, what Dr. Genti just told you. Every day there's a patient who comes and says, I had stopped taking because XYZ doctor said don't take it, but I think I need to restart. I see it every day, and sometimes I really get discouraged. But what keeps me going is my patients' love, affection, and my team, my family building up, which is happening with the support of Dr. Coimbra's blessings, divine blessing. We are doing the right work. Don't worry, friends. Take care. All the best to you all. Bye bye. See you soon. And I'll keep sharing on the group. Okay? Take care.